Seamus, we're now live.
Thank you, and good morning everyone, and welcome to today's virtual meeting of the Hertfordshire Health Scrutiny Committee. Due to the coronavirus pandemic, the Council will be holding this meeting electronically in accordance with the relevant regulations. Members of the public may also attend the meeting in an electronic capacity, and there is a link on the Council's website for them to do so. Members of the Council are asked to keep their microphones switched off until called to speak, and to switch their microphones off once they have finished speaking. Cameras may be left on throughout the meeting if members wish. If you're experiencing connection problems, i.e. freezing screen, that type of thing, or other technical issues, it may help to switch your camera off, and cameras should be switched on if and when speaking in the meeting. Members, to indicate to speak, you use the raised hand function in the participants box, and I will be monitoring that as we go along, as well as officers. At the end of each debate, each item of business, there will be a vote. This will happen in the chat box, and you can indicate for, against, or abstain. I will declare the result after each meeting, after each item. Breaks of at least 15 minutes will be held every 2 hours. So after a couple of hours, we'll have 15 minutes break. And will be taken after a speaker in the debate has finished speaking, so we won't interrupt you. And if we are voting, we'll conclude the vote and then have a break. Now that's the announcements that I've got to make. I can now advise that there has been a membership change, and that Simon Bloxham is substituting here for Fiona Guest for this meeting only. Apologies, I do not have any. Now, what I intend to do now is go round the everyone that's attending this meeting here today, and if they can introduce themselves. So if I can call, let me just get the list up, and I'll call everyone out so they can say whether they're present and a bit about them, where they represent. So if we could start off now with our substitute, just to be aware as well, there are 21 members and the quorum is 7, but we're fully quorate. So can I ask Councillor Bloxham if he can introduce himself?
Thank you, Seamus. I'm Simon Bloxham. I'm substituting for Fiona Guest, and I represent Letchworth North.
Thank you. And now can I ask Councillor Brown to introduce herself?
Good morning. I'm Councillor Susan Brown, and I represent Boreham Wood North, Boreham Wood.
Thank you. Can I now ask Councillor Eames Peterson to introduce herself?
Yes, I'm Councillor Margaret Eames Peterson. I represent Hatfield North Division, and I'm Labour spokesperson for Health Scrutiny.
Thank you. We've now got Councillor Greensmith, if she can introduce herself.
Morning, I'm Leslie Greensmith. I represent Goffs Oak and Berry Green as a county councillor.
Thank you. Councillor Dee Hart to introduce herself.
Good morning, I'm County Councillor Dee Hart, and I represent the Waltham Cross Division in the Borough of Broxbourne. Thank you.
Thank you. Councillor Hewitt to introduce himself.
Good morning, I'm Dave Hewitt, and I represent Cheshunt in the Borough of Broxbourne.
Thank you. Councillor Roma Mills to introduce herself.
Thank you, Chair. I'm Roma Mills. I have no video access. I represent St Albans North. I ought to declare a couple of interests, Chair. We don't have it on the agenda. I'm currently a member of the Mental Health and Learning Disability Integrated Care Partnership Board, and I work for Carers in Hertfordshire.
No problem. I was going to ask for members' interest after we've gone through this whole process, but I'm sure that's been noted down by Michelle. Right now, I'm Seamus Quilty, and I'm the chairman of the Health Scrutiny Committee, and I'm a county councillor from Bushey. We now go on to Richard Thake. If Richard can introduce himself, Councillor Richard Thake. Okay, I'm not too sure if Richard may be having connection problems, but he will.
Yeah, he's not with us yet.
Yeah, he might be having connection problems. Let's move on then. Councillor Ron Tyndall. I know Councillor Ron Tyndall's here because I've been chatting to him already. Ron, are you here?
Thank
Introduce
you.
yourself.
Ron Tyndall, representing Hemel Hempstead St Paul's.
And just to let you know, I don't know if your connection's a bit weak, Ron, but you were slightly quiet there on the microphone. But hopefully it'll pick up as we go along. Councillor Chris White, are you on the line there, Chris? I know you are because I was speaking to you. Would you like to introduce yourself?
Yes, Councillor Chris White, representing St Albans Central Division and Vice Chair of this committee.
Thank you. Now, they're the county councillors that make up part of the meeting. Now we move on to the district and borough councillors who are representing the various districts. So from Dacorum, we have Councillor Binder. Are you here online?
Good morning, everyone. Yes, I am. I'm Councillor Alexander Binder. Call me Alex. I'm a borough councillor for the Grove Hill Ward, and I am the Dacorum representative Health Scrutiny Committee.
Thank you very much there, Alex. If we call you that, that's fine. Now we move on to St Albans. We have Councillor Cousins, who's representing St Albans. Are you online, Councillor Cousin?
Yeah, good morning, everyone. Well, yeah, indeed, I am Councillor Cousins, Paul Cousin.
Thank you.
And I represent Harpenden North in St Albans District.
Thank you very much. We now move on to Welling and Hatfield. We have Councillor Fitzsimmons. Are you online there?
Yes, I am. Thank you. I represent, as you said, Welling Hatfield Borough. Thank you.
Thank you. And I can see Councillor David Lambert's there. So, David, would you like to represent yourself from Hartsmere?
Hello, I'm David Lambert from Hartsmere Borough Council, and I represent Aldenham, which is Radlett within the district.
Councillor McKay, I see you're down from Stevenage. Would you like to introduce yourself?
Hello, thank you. Good morning. I'm Maureen Mackay, Councillor Maureen Mackay, and I'm from Stevenage Borough Council.
And we have from Broxbourne, we've got Councillor Nicholson. Are you there?
Yeah, good morning, Seamus. Councillor Gordon Nicholson, Borough of Broxbourne.
Thank you very much. And from North Herts, we have Councillor Ngwali. Is it? I don't know if I pronounced that right, but I've given it a shot anyway.
She's not with us yet, Chairman.
Oh, right. Thank you. And then if we move on to Watford, we've got Councillor Parker from Watford. Are you there?
Maggie isn't with us either.
Right. OK. So and then we've got Three Rivers. Councillor, yes, I can see you. You're just looking at me. You're right in the middle of the picture.
Good morning, everybody.
Alison, introduce yourself.
Good morning. Alison Scarth I represent Three Rivers District Council on this committee, and I also represent Oxley Hall and Hayling Ward. Thank you.
So thank you very much. We've got now from East Herts, we've got Norman Simmons. Is Norman with us today? No, not at the moment.
Yes, she's 9.
Is she? She might have technical problems. Okay, well we'll move on. We know she's here online, so you've got that noted, Michelle. Yeah. Okay. Well, thank you very much for everyone that's introduced. And can we now move on to the? We know we're doing this electronically. We know all the rules and regulations and whatever about how these things work. If you want to I've got a bad signal. My signal's just come up, which says it's a bad signal, which could be a pain, but it seems to have disappeared now. If we can, on the chat box, we will use that just for voting and that type of thing only. It will be very confusing if people start putting messages on it. So if we can try and avoid that, we will, unless it's their messages from officers about technical details and that type of thing. Now, if I can now move on to members' interests. Roma has declared an interest. I'm wondering if anyone else has got to declare an interest, or are we all right? Yeah, there's no other interest to declare, then I'll take it that way, right? So if we go straight now into the meeting itself.
I think Alex Binder has a raised hand.
Sorry, to put my hand up, Chair.
Sorry, I missed it. Alex, you can carry on now. Interests.
Yes, I'm still involved with the Decorum Hospital Action Group website. That is changing, but it's not changed today. So I feel it proper that I should mention that.
Okay, it's non-pecuniary interest, if I put it that way.
Thank you very much.
So it's just registered as that.
Yeah.
Okay, no problem. Now we've done the members' interest. So now if we move on to the main part of the agenda, if we do approval of minutes, this was the meeting on the 30th of September 2020. Now I don't know whether we're going to have a members. Are we going to have a box? Are we going to have a voting box on this, or are we just going to agree it? If I
no, Seamus, members can indicate that they agree in the chat box, please.
Fine, members, could you indicate you agree that these minutes are approved? Chat box. Sorry,
if I may raise a point on the minutes, please.
Right. Okay.
I do not think paragraph 3.9 reflects my comments on the West Herts Hospital debate. My point concerning slides 31 to 34 on the Watford development expressed a great disappointment that a greenfield site was not included in the process for costings, and I believe the minutes should reflect that.
Yeah, okay, I think you did say that, Ron. I remember it well, and therefore the minutes should be adjusted. Can we adjust the minutes to reflect Ron's words, and then can we agree them?
Thank you, Seamus.
I think, oh yeah, they're all coming up along my line now, so I've. Michelle, can you say that there's a majority there now?
Yes, Seamus.
Okay, thank you very much. The minutes are now agreed, although you're still coming in.
Yes,
thank you for that, and welcome, Richard Thake. Can you just introduce yourself very quickly, Richard, because you weren't here right at the start.
My apologies, Seamus. Good morning, everybody. Richard Thake, member for Nebworth and Codicut. I do apologise. I had a 21-month-old grandchild and I was babysitting, and I have to say the pleasures of looking after him made me forget that the meeting was starting at 10, and I absolutely abjectly apologise.
Don't worry, we've all been there. We understand. Right, we've just done our approval of the minutes of the 30th of September, and now we move on to agenda item 2, which is public petitions, and there have been no public petitions received by this committee. So now what I'm going to do now is slightly alter the agenda and move to item 6. Which is the Hertfordshire and West Essex Vascular Network report. Can I say, I think that you'll find that in your pack on page 33 if you look. So who is presenting this? Do we have? We haven't.
I am Seamus, Sarah Brierley.
Oh, Sarah, right, okay. Sarah, do you want to present your report then?
I will do, thank you. Can you hear me all right?
Yes, we can.
Good, super, thank you. Firstly, Nick Carver sent his apologies that he's unable to join the committee this morning. He's very preoccupied with a range of other issues, as I'm sure you can imagine at the moment. I will take the paper as read. I understand that you just would like a sort of 5-minute update from us.
Fine.
Yeah. So I think the key things that it would be helpful for me perhaps to highlight to the committee are firstly a piece of probably historical context for this, for those of us that have been working in Hertfordshire for long enough to remember things like the Investing in Your Health consultation. There was a phrase that Nick Carver used at that time, which was about his real passion and commitment to ensure that Hertfordshire became a county that people travelled to for healthcare, not travelled through for healthcare. And some of those key areas are very much around the more sort of complex supra district general hospital services, of which vascular surgery is one. So Hertfordshire and West Essex is one of the remaining areas in the country that does not have what is considered to be a fully worked up vascular network. And vascular networks are very much predicated on the premise for complex acute work where you have a relatively low volume of high complex work. You need to be able to concentrate your resource and your patients into a particular location to improve outcomes and sustain improved outcomes. And that's exactly what we are together trying to do for vascular surgery. We, as Eastern North Herts Trust, have been working with our commissioners and also with West Herts and with PAH and Harlow. There has been some really excellent coming together of our clinical leads, which is just super to see. The trust and the network were awarded about just over £7 million capital a while back now through the STP funding streams to provide investment in the infrastructure needed at the vascular hub. So the proposed model in the future will be for a vascular hub in Stevenage and vascular spokes at both Watford and Harlow. And those will work very much together to on the principle of all work should happen in the spokes unless there is a reason why it should happen in the hub. And the hub work is primarily the less frequent, complex, planned and unplanned arterial work that currently goes on. We're working very closely with Professor Mike Horrocks, who you may have heard of, who is a very leading national vascular surgeon and very involved with the Getting It Right First Time NHS programme. And he is helping guide us through the very complex work of designing a totally reconfigured vascular service across the ICS. We are also identifying patients to be working with us as part of a patient forum in the next stage of work. These are not the easiest patients to identify because they are very few and far between. So what we are doing is very much working with our clinical teams on each of the sites to seek to engage previous as well as current patients in their interest in working with us as we test and refine our pathways over the next few months. In terms of the look ahead and the next steps, we are aiming to have completed an outline business case by the end of this financial year. It is a fiendishly complex process involving both reallocation and transferring of resources and workforce across an ICS to deliver really high quality vascular services. So it is a fiendishly difficult process, but we are confident that both by working together and also with the support of the ICS and specialised commissioners, we will be able to land that. Subject to that, we need to get NHS England an improvement approval of our business case in order to access the capital. And subject to all of that happening, and I realise there's quite a few subjects here, but that is the process. Subject to that happening, we expect the building work to commence later in the new financial year. And then we will proceed with the next stages, which are beginning to bring over emergency out of hours and then in hours vascular work from from Watford. We anticipate that will start in late 21-22. And to give you an idea of scale, in total across all the both the planned admissions and the emergency admissions, ultimately we expect about 350 patients to that would previously have been treated at Watford to transfer to have their care undertaken in Stevenage, and that will happen in a phased way subject to our engagement with them. So I will pause there and very happy to answer any questions.
Thank you, Sarah. And I've just put a headset on just so it'll reduce down any background noise at my end. So is there any questions for Sarah? We're asked to note this report. We will be doing it in a minute. Is there any questions? Any hands up? Can't see any yet. Give it another bit longer. No. Well, Sarah, I think you've presented your report very concisely because there's no questions. And we'll be looking forward to seeing the network open in about a year's time or thereabouts. Is it year and a half, roughly? Now we're asked to vote on this to note it. So Michelle. Sorry, how are we going to do this? Are we going to do it in a voting box, or do we just agree to note? Just agree it.
Agree to note in the chat box.
Okay, everyone, if you can agree to note the report, just say agreed in the chat. That would really help. And then Michelle, would you tell me when it's we've got a majority?
Will do, Chairman.
It's flicking through quite well. Must have got there by now.
It's in the chat box, Chairman.
Yeah, I know. I'm watching it. Is it? Oh, is it in there? Oh, I missed it. I missed your one, but all the other ones coming in. Well, thank you very much. That's agreed. That report, and Sarah, thank you for that, and we'll see you whenever. Come back in the future to discuss it again.
I will indeed, and I'll remain, if I may, for the rest of the items. Thank you.
Yep. Okay. There is Gordon. You've got a hand up. I don't know whether you wanted to speak on this subject or is it something else totally different? I've got hands coming up now, but we've already agreed it. Margaret, you've got your hand up. I don't know why.
I did try to ask a question earlier, actually.
I didn't.
What happened? Sorry.
Is
it possible just to ask a question, even though I have noted the report?
Well, yes, we'll let you away with it this time, but normally I wouldn't because of time pressure. But if you want to ask something, Sarah's here. She might be able to help you. Go on, ask away.
Could I just ask about changes of staffing as to whether there will be transfer of staff at all from Watford to Lister? I was back in those days of when we looked at the coronary heart disease framework, and I was head of public health intelligence then. I do remember Watford becoming a specialist coronary heart disease area, and we needed one more consultant then. I just wondered whether you were what you anticipate about any changes of staffing across West Essex and Hertfordshire between now and 2022 to accommodate your exciting changes.
Yes, happy to answer that. There is actually, as I'm speaking to you, a workshop going on virtually in cyberspace somewhere else that is specifically with the teams working through the workforce models at the moment. But in high level terms, we certainly expect surgeons from and anaesthetists and interventional radiologists to undertake sessions in the hub as well as in the spokes. And we also expect that the Stevenage-based teams will also rotate into the spokes so that they all have a familiarity with the network locations. So the primary impact we anticipate is on medical staff. but it is about sessions primarily rather than significant shifts of individuals. But that detail is still being worked through in the workforce model.
When might we know that, do you think, Sarah?
We will know that by the time we've completed the outline business case, because we need to understand that in order to complete the financial modelling. And that will be by the end of March.
We're going to move on.
Thank you very much. End of March.
Okay.
Thank you.
Yeah, Sarah, for taking that question. We're now going to move on as this that particular point, agenda item has been noted by the committee. Back to the actual agenda now, and we start off again with agenda item 3, which is the East of England Ambulance Service Trust report following the Care and Quality Commission inspection. And we have Tom Davis, the Chief Executive, online. I can see you there, Tom. So do you want to crack on with your presentation?
Good morning, Chair, and thank you for the invitation, and good morning to all your colleagues here today. I'm Tom Davis. I'm the Acting Chief Executive of the Ambulance Service. Substantively, I'm the Deputy Chief Executive, covering for our Chief Executive who remains on sick leave at the moment. Joining me today is Glenn Young, who's one of our Senior Operational Managers who covers your sector area. And we're both here to take your questions, but I'll just start with an update to the information that we provided to the pack. So I think it's fair to say that this has been a very challenging year for this organisation, and thank you to the chairman for meeting with me a couple of weeks ago and allowing me to update him, but I will further update you all now. As you know, we have had a CQC inspection in September. Following that inspection, we have been put into special measures by NHS England and Improvement. Since the writing of the report, we've had further colleagues join us from an improvement team from NHS England. So we now have 2 improvement directors, one focused on organisational development and one focused on clinical aspects of the organisation. We have an organisational coach, and the 3 of them form an improvement team that's supporting the board and the executive director team. Along with that improvement director team comes additional funding to carry out the work and the extensive work that we need to do to address the challenges that the CQC have highlighted in their report. Clearly, one of the main focuses of the CQC report is the culture of the organisation, and since September we have done our own organisational survey into bullying and harassment. We had over 2,000 people speak up through that survey, which is a great acknowledgement that the organisation is prepared to speak out. The team have had over 76,000 data points to analyse. And unfortunately, what it tells us is not dissimilar to the CQC report, which we shouldn't be surprised by, but that the organisation does have bullying and harassment occurring at every level up and down the organisation and across the organisation. And that's not unique to one geography, unfortunately, that's across the board in every sector of the regional organisation, so the 6 counties that we cover. But what's important is that these behaviours are taking place at multiple levels of the organisation. It's far from a case of managers versus staff. This is happening between peer and peer at staff frontline level. This is happening between staff and managers, managers and staff, managers and managers, and unfortunately between patients to staff. And we know through our own complaints that we have patients raising concerns about how they feel treated by our staff. So clearly this is a significant challenge for this organisation at what is a very difficult time for the health service anyway. We've not waited for the survey to continue the work. We've had additional resource brought in to support our safeguarding and our HR functions. And as I've mentioned, the improvement team has joined us over the last couple of months. We also had a culture director join us and 2 senior experts in communication engagement to improve on the areas that have been highlighted both through the surveys and the CQC report. We've got specialist culture teams at multiple sites within the organisation, so 18 teams and over 50 different actions going on to work with staff and managers in improving the challenges that have come through both the survey and through additional people speaking up to our Freedom to Speak Up Guardian and to our Culture Director. And I'm happy to detail further actions that we're taking. In the interest of time, I just wanted to further update you on performance and preparation for winter, and then very briefly speak about the structure of our improvement plan. So performance for your constituents has continued to improve over the year. We have delivered national standards to our most sick patients since May this year and continue to do so up to this point in December. We are, as the rest of the health service, experiencing an increase in demand, but we feel well prepared for the next 2 to 4 weeks in particular, where the pressures are likely to be at the highest. We're working with our system partners. Glenn will be able to detail daily conversations that he has with the Hertfordshire system and the acute partners and the commissioning partners within that system. We are delivering more than 10% increase in available ambulances to our patients at this point of the year compared to this time last year. But we are also acknowledging that with the challenges of the pandemic and winter, that there are many challenges that lie ahead, and we need to keep that focus to ensure that patients get that ongoing service. So finally, I just wanted to touch on the structure of the oversight of the special measures. We are meeting regularly with our regulatory colleagues, the CQC and NHS England and Improvement. That's happening on a monthly basis. I'm involved in a number of meetings ongoing with the National Intensive Support Director and the regional directors as they support the trust to continue to deliver care, but also to address the cultural challenges that we have acknowledged and accepted through the CQC report and the subsequent surveys. Other regulatory oversight, we have oversight at the moment from the Equalities and Human Rights Commission. We're currently working with them to develop an action plan specifically around our ability to prevent sexual harassment within the organisation. And we're also working with the Health and Safety Executive, given the COVID pressures and the need to ensure safety to our staff and patients. So I'm afraid a challenging picture from this organisation, but in the spirit of openness and transparency, I felt it's important to give you that update. So thank you, Chairman.
Thank you. Thank you very much. I should draw members' attention to 2.1 in the report, which is the summary, on the first paragraph of the summary, where it lays out in very short words the actual CQC published inspection report. And it's worth reminding ourselves at this point that the caring that the organisation does is outstanding. There are some on the other side of the coin, the effective and to the Fed. So there's a pretty broad results there. Now I have Dave Hewitt Councillor Dave Hewitt who wants to come in as the first questioner. Dave.
Thank you, Chairman, and thank you, Tom, for your report, which I've read with interest. A general question, really, particularly as Hertfordshire, as everybody knows, has moved into Tier 3, and we see on the television scenes of ambulances queuing, not in Hertford that I've seen yet, or in Harlow, because most of my residents receive their acute care in Harlow, of ambulances having to treat patients in the back of their ambulances. Are you experiencing these difficulties, and are there plans in place to ameliorate any problems, particularly over the crucial Christmas and winter period? Thank you.
Thank you. Do you want me to answer?
Yes, carry on, Tom. Yeah.
So thank you for your question. I think absolutely pertinent to the situation we find ourselves in. Whilst this is something that we're seeing across the country within hospitals and within ambulance services. Clearly, we have a responsibility to our patients in this region. I think it would be wrong to say that we're not experiencing delays. So we continue to experience delays, but we continue to work with our system partners, especially our acute trust colleagues. Glenn will be meeting on a daily basis with his counterparts within the hospitals. We have daily oversight and monitoring of the safety of our patients within those waits as they wait for hospital handover. With regards to, will that continue? Yes, it will continue. I think there's an ambition within the system to make sure that it doesn't deteriorate, but it is a reflection or a symptom of the pressure that the NHS is experiencing across the board, both at the front end of our hospital, so into the communities, and at the front door of the emergency departments. We do have a number of mitigations that we put in place. The additional resource that we are able to put into the daily rosters is part of that mitigation. So as I said, up to 10% more ambulances this year than this time last year. We're also working in partnership with our fire colleagues and the military to further increase our ability to respond to our patients in the community. We have a number of measures that we can put in place, so looking after patients in the back of the ambulance if it's absolutely required, and mechanisms whereby we can release ambulances back into the community where the patient is at most risk when they're waiting for an ambulance with obviously no healthcare provision at the point of care. As I said, it's a daily conversation, it's a daily oversight, and there are proactive actions that go in both from our perspective and the hospital's perspective. But I would be wrong to sit here and assure you that it's not an issue and it's not going to continue to be an issue. But it's an issue that we are aware of and mitigating through the actions to keep patients safe, albeit we acknowledge that the experience of delays in the ambulance are not good, but the safety is the ultimate and the paramount importance.
Thank you, Tom, for the answer. And I've got four other questioners that want to come in now. So I've got Margaret Eads Peterson, I've got Councillor Cousins, I've got Councillor Mills, and then I've got Councillor Greensmith. So I'm going to start off with the first one I mentioned, and that's Councillor Eames Peterson.
Thank you, Chair. I just wondered whether I could ask Tom, have there been effects on staffing and sickness absence from mental health issues as a result of some of the harassment experiences of staff particularly? And yes, if you could just expand on how that has had a wider effect on your service. Thank you.
Thank you. So I think on an individual case-by-case basis, it absolutely you can see the impact on individuals from a mental health perspective, and that's not something I sit here with any pride over. The inefficiencies of our mechanisms and our processes have meant that people are in often individual employee relation processes for many more months than is ideal. And that clearly has an impact on all parties involved in those processes. We have a very good wellbeing service through our occupational health team with crisis provision as well as counselling provision. But again, I'm not going to sit here and say that people aren't affected by the culture of the organisation and by the challenges that the CQC have highlighted. Unfortunately, many of them are process related, so capacity of our support services to carry out efficient processes. But I think on an individual basis, yes, unfortunately, people are affected from a mental health perspective. I think from a wider organisational perspective, we've seen some great work from the management teams in supporting staff in sickness, both in long-term and short-term sickness, and obviously with the challenges that COVID symptomatic and asymptomatic stand downs create. That's not in any way been easy for those teams and for the individuals. Our overall sickness rates for the organisation have been improved over the year, so coming from 6% down to 5%, and I think that's a recognition of all that commitment and hard work. But so on a global organisational perspective, mental health is not impacting our ability to deliver care to our patients, but on an individual basis, those members of staff, whether they be managers or frontline staff affected by individual cases, unfortunately, there is a recognition that there's an impact on their mental health.
Thank you, Tom. Can I please just remind colleagues, try not to use the chat box for anything else apart from voting, because it can be it's very confusing for officers to try and monitor everything at the same time, and it helps a lot if we don't do it. But now, so if I now move on, we've got Paul Cousins from St Albans, I think, next. Yes, Paul.
Thank you, Chair. Tom, if I were to think of showing a list of professions, if you like, where I would sort of almost like expect harassment, sexual harassment, bullying, I must admit that an ambulance service would have been sort of right down at the bottom of the list. Mm. Is this the case with other maybe to a lesser extent with other ambulance services, or if not, sort of how, I don't know, like how did it get to this? Is it in recruitment decisions made 20 years ago, or yeah, how did we get to it?
So thank you. A good question with probably not an easy answer, but I will try. I think it would be inappropriate for me to comment on other organisations, because I don't have that level of understanding of those organisations, and our conversations with the CQC and the regulators have very much been focused on this organisation. I think we have found a culture that may not be dissimilar to any sector and any setting of any service, whether that be public or private. But you know, I don't have the evidence to be able to give you that from an objective perspective. But from our perspective, a lot of this culture is complex, to say the least, and the culture director is has used the phrase for me that we have 120 cultures within a culture. You know, as an organisation, we are geographically very dispersed. We represent multiple communities and very different communities, albeit within the geography of one area of England. And I think the culture challenges reflect very much that complexity. I think an ambulance service also has a relatively geographically isolated workforce. And this is one of the main things that the board is working on with our regulatory input, is how does the board understand what's going on at a station that may only have 10, 15, 20 members of staff working there? How can we be assured that the culture there is a positive culture, as well as being assured that the culture that we deliver as an organisation, as a team, is a positive culture? And I think it's, you know, it's incumbent on all levels to look at themselves in the mirror and change what's going on.
Okay, Tom.
So yeah, sorry, I can see lots of hands going up. So
yeah, that's a problem. That's a time issue for me. So we've got Roma Mills who's first, then Gordon Nicholson, and Leslie is actually, you've answered her question already previous, so she doesn't need to put forward a question. So Roma, you're the first one off.
Thank you, Chairman. I'll keep it brief. Thank you very much to Tom for a very honest presentation. I think it must be very tough to be making a presentation in the wake of that CQC report. I entirely take on board the Chair's remarks about the very positive things that were found, you know, the results in terms of caring and responsiveness. But I do see some conflict there, because it does seem to me extraordinary that a caring organisation would then have flagged throughout its organisation. I think that's the worry, at every level in its organisation, bullying and harassment. Now, I take on board the things you've done, the consultation with staff, the update on what I would describe as responsible reporting within the organisation. But how can you monitor such a huge organisation as the East of England Ambulance Service to really drill down into the culture at local levels?
Thank you. I'll try and keep my responses short, but I think it's a very pertinent question. I've just gone through a process with the National Intensive Support Team and the Regional Director Team from NHS England to look at that very question around is the size and structure of this organisation part of the root cause of the cultural challenge? We've done a very detailed analysis with experts from outside of the organisation, and we believe that the structure of the organisation is the right structure. So we have a business unit structure whereby the locality delivery of services and support for staff is done from our 6 locality level sectors. And the feeling was that that is the right structure, but what we need to do is look at the capacity of our support services to wrap around those business units, and then the capability of the leadership at that business unit level. So it is a very pertinent question. I think part of the solution is getting that structure right, so that there is accountability at a local level that is then assured by the central level of the organisation. And so I suppose a hub and spoke model to the organisation that we have in principle, but I think we have a lot to do to make it fit for function.
Seamus, you're muted.
Apologise, I was muted. I was flicking around between the chat and the other one, trying to see who was next. Gordon Nicholson from Broxbourne. Gordon.
Yeah, thank you, Seamus. Going back to the comments earlier about the handover delays, have you any emergency plans put in? Because I remember a few years ago when we had an epidemic, not a pandemic, and there was a hold up, and I think I was in Lister at the time, and some of your staff set up a desk within the reception, which actually speeded it through, was a very great help. And I wonder whether or not you'd set up any plans along those lines in case that would be needed. Thank you, Mr. Chairman.
Thank you. So absolutely, and a great observation. Thank you. That is now a business as usual function for the organisation. So the learning from the previous years highlighted the need to have an officer from the ambulance service working within the back door of the emergency department. So we now have at all our hospitals in the region almost 24/7 cover of an officer who works alongside the staff of the emergency department to improve that flow, to oversee the safety of patients in the ambulances that arrive, and to work with the hospital teams in prioritising the needs of those patients. In addition to that, the hospitals work with us to create space within areas of the emergency department that aren't bedded areas, so that we can look after patients safely within the building rather than within an ambulance. But then, as I said earlier, we have further measures where we can look after patients safely in an ambulance, albeit not ideal, and then further mechanisms for hospital consultants to oversee the safety by triaging some of the patient needs in the back of the ambulance. So the specific answer to your question is those are now business as usual functions, but I've described some additional mitigations that we will enact throughout the next couple of weeks, I'm sure.
Thank you very much. Very, very helpful. Thank you.
James, you're muted.
Sorry, I was muted again, Richard. Yeah, you're right. Councillor D. Hart, please.
Thank you, Chairman.
We've lost you there, Dee. I can't hear you. I don't know if anyone else can.
Can you hear me again, Chairman?
Just back.
Okay, right. The Mental Health Emergency Clinical Advice and Triage Centre. What alternative care pathways can be offered to patients, please?
Thank you. This is an area of the organisation that has grown over the last 4 to 5 years. We now are able to offer patients the right pathway without actually physically going to see them. So we now offer that service to up to 10% of our patients every day. Part of that triage service is, as you say, the mental health aspect. We've employed specific mental health clinicians to support our generic clinicians within the control room to ensure that we're not only assessing mental health patients more effectively, but then we're able to access pathways that we may not have been able to do previously. So we have a mental health lead who's worked very closely with all the mental health services and the commissioners within the East of England. We now have entire coverage of the region, so that includes Hertfordshire, whereby either through our clinicians in the control room or through our frontline staff who are visiting a patient, we can directly access some of the mental health services within the geography. So I think what it has achieved is an improved assessment and an improved accessibility for our mental health patients to pathways that aren't ambulance delivered. So partnership working with our mental health and our commission colleagues.
Okay, thank you, Tom, for that. And I have got no one else who wants to ask any questions. Tom, I think it's been a good, frank, open and honest sort of report. You've indicated that there have been problems, and you've indicated the ways that you're planning to work out of those problems. We've noted that the Care Quality Commission have said that it is a mixed bag. Some of the caring side of it is outstanding, but then there is the well-led, the management side of it is inadequate. And you've given us a good indication how you intend to work your way through that. So, colleagues, we're asked we're first of all asking that if you to vote on this. We've talked about in certain cases identifying any future actions, and I think one of the ones that I think was a very good action that we suggested and was suggested that following practice that you've done in the past is having a desk in the hospitals. We've identified that, so that's really good. We're going to ask you to return in the future to update us in relation to how's it all going and if there are any other problems at that particular time. So can we have the vote box up? Please don't go into the vote-in chat at the moment, because we're going to use a vote box, I believe, and it will get very messy. Hold on.
You're a bit late on that one, Seamus.
Yeah, I know. I'm going to have to close them all down so we can find a vote box. Are we doing a vote box, Michelle?
No, only vote boxes are done at County Council.
Ah, right. Okay. All right then. Well, that's interesting because yeah, that's what it said in my notes. So go back to the chat box, please, everyone. Start agreeing or not, whatever the response is going to be.
The majority is agreed, Chair.
Yeah, I think so. Okay, well, thank you very much, Tom. We've agreed that, so we'll look forward to seeing you in the near future or whenever you've got some news for us. You can always pop it across to Natalie and she'll share it with the committee. So thank you very much.
Do you mind, Chair, if I duck out now?
No, yeah, of course. Totally understand. You
wish everyone a Merry Christmas and a Happy New Year.
Yeah, fine. Well done. Well done. Okay, we now move on to agenda item 4, which is the Mount Vernon Cancer Centre Strategic Review Update. This can be found on page 19. It's going to be Jasmine. Here we are. Will you be starting this off for us?
Yes, I will. Thank you. Sorry, I just had to turn my camera off momentarily because the signal was a bit poor.
I know.
Thank you, Chair. The paper that you've had sets out the work that's been taking place over the last few months ahead of December's programme board. I'm going to take the paper as read. I'm happy to answer any questions on it, but what I want to do is just really update, because the programme board has happened recently. We have issued an update, a stakeholder update this morning, which I'm sure Natalie will send on to members. but I just thought it worthwhile highlighting what the recommendations were that are referred to in the report that went to the programme board and what happened at the programme board, plus a little bit about the engagement that we're doing over the next couple of months. So the first substantive item that the programme board discussed was the patient and public engagement report. And members saw a video of patients sharing their views, which was quite helpful because it meant that the discussion was very much focused on patient views. We then discussed the clinical model, which is referred to in the paper in terms of the work that the clinicians had been doing to look at which of the two models really that had been recommended by the independent clinical review was the right one for the Mount Vernon Cancer Centre. And they recommended the single site model, so moving the whole of the cancer centre, as it were, onto an acute site, rather than the other model, which was called the ambulatory model, which would have meant leaving a service, a day hospital, as you like, on the Mount Vernon site. And they've done a lot of work on both of those and concluded that the best option for the Mount Vernon services was a single site centre. That is actually supported by the patient feedback. Patients were very keen that the staff team was kept together, that the centre was able to deliver the most specialised care it could, do lots of research, and felt that a consolidated centre would enable that, whereas splitting the resource across two sites might fragment it, would fragment the team, and might mean that it wasn't able to be quite as focused and specialist as it otherwise might. I think what's worth noting, though, was that the patients did make lots of suggestions for care that could actually be delivered more locally. So blood tests came up quite a lot, for example, patients travelling all the way to Mount Vernon just for a blood test. And also chemotherapy, which isn't available everywhere at the moment. And so the agreement from the programme board was to progress the planning for a single site model, but with enhanced services locally. So looking what we can do in local areas and how we can make sure that patients that don't really need to be treated in a specialist centre could be treated more locally without focusing all of that effort onto a second site, but enabling us to be able to deliver things closer to where all of the population live. As you'll recall, it's a very large population that stretches up to Bedford, into Ealing and Brent, across into Berkshire and Buckinghamshire as well. So that was the clinical model, and the board supported that recommendation. It is still a recommendation because the programme board is advisory, it's not a decision-making body. The programme board went on then to hear what each of the ICS views were. So Herts and West Essex had provided us with some information about their cancer strategy, their population needs, projected changes, challenges, that kind of thing. And there were 6 ICSs involved. We have 6 in the Mount Vernon catchment. Herts and West Essex is the largest, but by no means the only one. And there was a long discussion following that information about health inequalities and health outcomes, which are particularly poor in areas such as Luton. We're not quite sure why Luton is an outlier, but it is. And that information was all presented to the programme board, and it was a very good discussion on that, with some further work being commissioned around looking into areas such as Luton and trying to understand what's happening there. And then we went on to the location discussion. It's all very well, as you know, planning for a single site centre that needs to be on an acute site, but there are about 10 potential hospital sites in the whole of the Mount Vernon patch, and we needed to narrow it down. And we'd set some criteria for that any potential site had to meet. The first one was based on the independent clinical report, which said that it must have an ITU. The second one was that it had to be co-located with certain other acute services, and we commissioned a second independent clinical report to identify exactly which those services were. And the third criteria was around access. And access we had agreed we would measure in terms of car access and public transport, and I'll just quickly tell you what those were because I think it's quite significant. So for car, the criteria was that there had to be no material deterioration in average travel times, and a material deterioration was considered as an increase of 5 minutes or more on your journey time. No significant increase, so 5 percentage points, in the proportion of patients with a 30 minutes or more travel time. And then for public transport, no material deterioration, which was considered as an additional 5 minutes on the journey in travel times by public transport, and no increase in the proportion of patients travelling more than 75 minutes each way. So to meet the public transport criteria, you had to both not add more than 5 minutes to the average journey time, but also not increase the journey time for those who already have the longest journeys. And when we assessed all of the site options against those criteria, there is actually only one site that meets them all. There are 2 sites that fail on one of them, one of the criteria, but only one site that meets them all, and that is Watford. So the programme board have agreed to do some detailed work around the feasibility of a Watford site option, and that would mean a cancer centre situated alongside Watford Hospital on the so it wouldn't be part of the building, the services wouldn't be inside the Watford Hospital building, it would be its own building. Patients did express a desire for a physical link so that any transfers that needed to happen could be done in the dry, but we're not at that kind of stage of detail. We're looking at the feasibility of it. It would mean Watford, who already provides some support to Mount Vernon, would provide the majority of the support services that the cancer centre itself does not have. So there's a lot more work to be done. We also, as part of that, need to therefore look at, as we're enhancing local access, what we can do in areas such as Hillingdon, for example, where they don't have chemotherapy at the moment. So looking at whether we can add chemotherapy into Hillingdon, sorry. And we are talking, as you know, to other areas, other scrutiny committees, and we've had quite some significant support from North West London. And it's probably worth reinforcing that North West London are on that programme board and we're party to that support of that recommendation. And then finally, just very quickly on the future engagement, we have a whole load of new events that have been published that are available for people to book into. We're particularly looking, we're going to have a regular twice-a-month update slot, just a general update on the programme. But we're also looking at trying to do some geographical events to explore what would a Watford solution look like for people in different areas, to test out how feasible it is. So in Hertfordshire, we've got events in Welwyn, Watford, Stevenage, and a St Albans and Hemel event. At the moment, those are online. They're not going to be physical because obviously the government guidelines at the moment prohibit that. But we will try and make sure that they are local somehow. And the new website has gone live, which enables people to join discussions online, have their say, share ideas, and that will continue to evolve. So those are the main things that I wanted to say. Thank you, Chair.
Okay, thank you. We've got one questioner that wants to come in straight away. That's Councillor Richard Thake. But before he does, I should say that I've got loads of hands coming up now. But I should say that this is just it's just in the infancy, or it might even be younger than that. This is just at the start. It's a marathon that's going to go on here. It's going to be a long time before there's any real decision made. So please just bear that in mind, that Jessamine is only just indicating, it's an indication of where this is likely to go, but it's no more than that. So right, over to you, Richard. You're the first one that.
Yes, thank you, Chairman. It was absolutely on. I mean, 2 things. Firstly, Jessamine, thank you very much for the common sense approach in terms of taking your initial paper as read. I wish more would do that rather than spend hours talking to it. And thank you for that wonderful sort of resume of the fact that we are, shall we say, pregnant, if nothing more. If I may use that term. I accept absolutely what Seamus is saying, and it's precisely the point that I was going to make, that we have had, shall we say, a rather bad taste, I'm being blunt here, a rather bad taste in the mouth about proposals for Watford the hospital and the surrounding area in the past. And it would be an absolute tragedy if one of these proposals was to founder because of the problems with others. I just highlight that because, as far as I'm concerned, while I remain on this scrutiny, I would very much want to track the twin improvements that you're talking about. I absolutely understand the work that you've done about trying to get the best experience for patients, and I'll leave it at that. But just to flag up that there's an awareness that we collectively need to look at a holistic site, the holistic solution, and the glittering prize of a purpose Mount Vernon replacement is wonderful, but there are other issues there, and I leave it at that, Chairman.
Okay, I don't think we need to get into them, Jessamine, at this moment in time. Councillor Cousins, you're next. Paul.
Thank you, Chair. I just wondered the travel times to the hospital. I mean, I can understand why Watford is the obvious choice, but I'm just wondering how the travel times are calculated, because where I am in Harpenden, you know, if you were to get to Watford Hospital for lunchtime one day, it probably wouldn't take you very long. It'd be quite easy. But if you had to be there for 8:45 in the morning, you know, it could take you double or triple the time.
Yes, thank you. I will have to come back to you exactly on how they've been calculated, but my understanding is that they have been calculated across different times of day. It's been modelled by a company that does this sort of thing all the time, so we haven't just tried to do it ourselves. We've gone back to them asking lots of different questions, asking them to do it in all sorts of different ways. There are pages and pages and pages of travel data. We will publish them actually on the website so that people can look through them themselves. But my understanding is they've considered rush hour impact as well.
I think, Jessamine, the easiest way of doing this is when it is going to be published on the website, if you could let Natalie know, and then she can sort of ping round an email to everyone, giving a link to that site, and any other information. All information will be on that site anyway in due course in relation to this topic. Right, so Councillor Gordon-Nicholson. Gordon, are you there?
Yes, thanks, Seamus. Yeah, good morning. Thank you. Very, very interesting. I noted that you were talking of public transport, and that's brilliant. Wonderful job. And I take it, and I know it's a silly question, but I'd like to hear the answers, that you have taken in transport links in times of accessibility, because if you have to change 3 or 4 times, or there may not even be links to these various places, I take it, and I hope that you have, that it will be a major part of your planning. Secondly, thank you very much for mentioning all these things happening on the website. But I recently read a report that came through Health Scrutiny that there are quite a large number of people that A, can't access it, B, have no methods to access it, or any knowledge of it accessing it. And so within that report, following that report, I hope that you also, along with a lot of other people, bear this in mind and not have to be prompted, but it should be part of your action plan. Thank you.
Yeah, I think Jessamine's nodding, so yes is the answer.
Absolutely, yeah. We've got lots of different methods.
Yeah, okay, thank you for that, Jessamine. Now, if we now move on to Margaret Eames-Peterson, she's got a question to put to you.
Chair, thank you, Chair. And thank you, Jessamine. And thank you for this sort of first, I think, most concrete, suggestions and outcome of your talk so far to do with Watford being selected. I am just going to say that in the history of cancer care, I'm a little bit disappointed that you're just trying to replace what are the current travel times to Mount Vernon, because Mount Vernon has been on the edge of Hertfordshire, and we very nearly had a new cancer hospital located in Hatfield that then got shelved back in about 2005. And we've been really wanting this cancer reorganisation and waiting for it for 15 years. The fact that Watford is still right over in the southwest doesn't really help the travel times from the rest of the county. And so I would have hoped you might have considered travel times in a more equal way, actually, given 44% of your patients are from Hertfordshire. I do realise 28% are from London, and you have a, Mount Vernon is the cancer specialist hospital of the area. You may have heard the previous item on vascular care, on having a hub and spoke model of care. I was going to say, have you considered that as well, particularly for Hertfordshire at the moment, and considering how we can use the secondary care hospitals and possibly other healthcare buildings that already exist for chemotherapy and blood testing, especially once they've been diagnosed. How can we get treatment much nearer to the patient is what I'll probably put it into the consultation. And I should just say thank you to Natalie for sending around the details of the meetings in the new year so quickly this morning. So I've seen that and the public consultation. But if you could just reply, I really don't feel that the way you've measured travel times is really very fair to the history of what we've been waiting for cancer care for Hertfordshire. And particularly public transport to Watford isn't that easy at the moment. We will have to.
Yeah, Margaret, I think there's a very clear answer, and Jasmine can give it to you here, about the potential possibility of satellite operations. Over to you to answer that.
Yes, thank you. I mean, we need to put the Mount Vernon Cancer Centre onto an acute site. There are only 2 acute sites in Hertfordshire. So that would have either been Watford or the Lister, and the Lister would have increased people's travel times from other areas by extraordinary amounts. We do completely understand. In fact, I deliberately played the first patient story I played at the programme board was from an East and North Hertfordshire resident talking about their trouble and their treatment choices as a result of that, because it is important that we acknowledge that. We have to be very careful not to completely disadvantage other areas, though, and there are some very deprived areas in other parts of the borough as well, where people are absolutely reliant on public transport to a greater extent. So there's a massive balancing act that we have to do, which is why we chose the range of measures that we chose. And the Lister just would not have been acceptable, and we would never have got anything agreed or done. And I think the Watford site offers. It brings it into Hertfordshire. It isn't too big a move for people in northwest London. We do expect that some northwest London people might choose to travel into central London. In terms of the networked approach, though, we do have chemotherapy already in a number of district general hospitals. We are looking at what we can do to enhance that. Patients were very clear that they would like to see IT systems talk to each other better so that they can have blood tests and things like that locally. We are looking at what we can do around that. We have agreed to do more work on the radiotherapy issue. We absolutely recognise that people in North Hertfordshire and in South Bedfordshire have a very long travel time for radiotherapy. So we are going to do some more modelling around that on the assumption that the base might be Watford for the main centre. So your idea of a network model is absolutely the sort of thing that we're looking at for chemotherapy and potentially for radiotherapy as well. So we're at an early stage, but we are very cognizant of the need to try and make as much care as local as possible. And so I think the engagement events that we want to hold locally will be about how can we make the patient experience better and easier within the restrictions that we've got, really.
Okay, thank you for that answer. It's very clear. We're now going to move on. I did see Steve Palmer's hand up, but it seems to have gone down again from Health Watch. I don't know, Steve, did you want to come in?
Yes, thank you, Chair. Just briefly, It seems to me one of the things that would really transform the way this goes forward is if chemotherapy and blood tests could be done locally. That would profoundly affect people's need to be able to use public transport, because what services would be left would make it very difficult for people to actually be able to use public transport to access them, because they would require quite a long, most of the services that would be then left would require quite a lot of treatment that make sort of people being able to sort of use public transport very difficult. I don't know whether that's been brought into the planning, because that would actually quite transform the service if you actually take out chemo and blood tests from being done locally into being done from being done at Mount Vernon and its replacement to being done locally. That would have a transformative effect, really, I think, on the service.
Yes, at the moment, a lot of chemotherapy is done locally, but there is potential that we could explore how we could do more of that more locally. And we've looked at some of the things that came up during the engagement that we did was around mobile chemotherapy, chemotherapy at home. We're talking to other cancer centres that have this kind of a networked model as well, to see what we can learn from them. So it's very early days, but it's just something that we're very, very well aware of. You know, let's keep the cancer centre for the really specialist complex stuff and see what we can network out. Staff are keen that they get the opportunity to work in the specialised centre and aren't running around between lots and lots of different sites. So we need to bear that in mind as well. But we do need to look at what opportunities there are to bring care closer to home. I know that's a bit of a jargony catchphrase now these days. And for example, Luton do a little bit of immunotherapy. Luton and Mount Vernon are the only two that provide the immunotherapy service. But there's a potential that as immunotherapies become more commonplace, they could do more of that. It may be that other centres, I'm beginning to speculate, which I'm a little bit reluctant to do, but there's certainly discussions being had and that can be had around that. And that's one of the principles around the clinical work stream developed, was around wanting to provide as much closer to home as they could.
Okay, thank you for that. Now, my last question or comment is coming from health organisation. Sarah Briley wants to, from the East and North, would like to say something. So, Sarah, here we are. Welcome back again. You're on mute. Mute.
Can you hear me now?
Yeah, we can hear you.
Sorry, apologies. At the risk of being highly predictable, you would probably expect me to just remind the committee of the very, very long-standing commitment that both East and North Hertfordshire and our MPs have had to improving access for cancer services, particularly radiotherapy, which, as Margaret referred to earlier, is one of those treatments that there are very, very long travel times for patients. And we are working with the review, and I think it's an excellent piece of work that Jessamy and her colleagues have been leading. So we are fully supportive of that, but we are pushing very hard for the inclusion of satellite radiotherapy within the Stevenage, North Hertfordshire area as part of that model. So I'd just like the committee to note that, please.
Thank you. I think it's duly noted. Well, it's a big bit of news that we've heard this morning, and as Richard Thake, Councillor Thake, has said, we're at an incredibly early stage here. So I think what we'd like to do would be to note that the committee considers the implications of the report and acknowledges that it informs its future work moving forward. And can you do that in the chat box now, please?
Chair, while people are doing that, do you mind if I just add one more comment, as I think it's probably important to reinforce for the committee?
Yes, you can. We're not going to open it up again to questions.
No, that's fine. It's just,
okay.
Just I want to be very clear on, we don't yet have a capital solution for this project. So we're talking about developing a service on a site. We're still looking for the funding for that. And I think the committee needs to be aware of that. Our intention is to undertake public consultation in the summer. And I know we've had discussions previously about setting up a joint scrutiny committee with the other scrutiny organisations that we're talking to. But that we'll need to have found the money before then. So I just thought it worth stressing before we get too carried away with the idea of a new centre. There's a lot of work to do.
Okay, and yeah, no, I understand. This is what we're saying. It's incredibly early days, and thank you for giving us the heads up on it anyway, as you've done today in this particular report and the verbal update as well. So I think we can say it's all noted. So, and the majority well over the majority have agreed it. So thank you very much for that particular item, and we'll now move on to the next item, which is the acute mental health bed provisions in East and North Hertfordshire. And I'm not 100% sure is it Sandra is who's actually going to present it?
Thank you, Chair. I'm going to hand over to Keith Loveman first. I'm afraid it's going to be a three-pronged approach, if that's okay. So that'll be Keith and then Dr. Farrow and then myself. So I'll hand over to Keith. Thank you.
Okay, fire away.
So thank you very much. Good morning, and thank you, Chairman, but also thank you for inviting us today. As Sandra said, I'm Keith Loveman. I'm the Deputy Chief Executive at HPFT, and I have my two colleagues with me, Dr. Joe Farrow, who's the Clinical Director and is a consultant psychiatrist, and Sandra has just introduced herself. If you're happy, Chair, that we will take the paper as read. It's a briefing note. We will just give a little bit of additional detail to that, but then obviously more than happy to open things up to any questions or comments. I'll just give a little bit of background. Dr. Farrow will talk a little bit around the clinical and the quality case, which mean we need to do something differently. But also we'd like to talk about how we would want to work with yourselves and others in developing the thinking and the ideas that we have. So it's really an initial toe in the water as a briefing and an opportunity for your questions and comments. And we recognise fully we're going to need your support as plans get developed, etc. So we want to make sure that we get this right. In terms of background, I'm sure some of you will recall the long history behind public consultations, such as Investing in Your Mental Health, which was back in 2006, where the then Bedfordshire and Hertfordshire Health Authority set out a journey for development of mental health and learning disability services. But obviously a lot of things have changed since then, including more than one reshuffle of health organisations. However, we think the core principles of providing consistent high quality services, joined up care, high quality modern inpatient mental health facilities for the residents of Hertfordshire, they certainly remain. And you'll see from the briefing paper that we've set out the 5 key principles that we think underpin achievement of that goal: keeping people safe, keeping people close to their communities, giving them the best experience thereby, and providing high quality environments, but also delivering equitable service provision across the county and ensuring we have the right number of beds in the right place. And as I say, today we want to start the conversation with you about how we can best do that and share some of our early thinking, but recognising it's critical that we do this in partnership. What the paper says, there are some things we absolutely need to resolve, and that now is the time to do it. Just to add a little bit of detail into it, we've got an inequitable service provision across the county. So 76 of the adult inpatient beds are actually in West Hertfordshire, and they're centred on St Albans and the Kingsley Green site, which is near Radlett. And only 22 of our beds are in East and North Hertfordshire at Aston Ward, which I suspect some people are familiar with, and that's on the Lister Hospital side. So, you know, broadly 75% of the provision is in one side of the county. But our service user admissions, and as you would expect, reflect very much the more urban areas. And that means, for example, if you live in Stevenage or Bishop Stortford or Cheshunt, and Aston Ward in Stevenage is actually full, you're likely to be admitted to Kingfisher Court, so some way away from home or from your family or your friends. And that's a poor experience for people because they've quickly become disconnected from their communities. We've also got an inequity in the quality of our environments. So if you compare the £42 million new build award-winning Kingfisher Court at Kingsley Green, which some of you may have visited, and you compare that to Aston Ward on the Lister Hospital site, which is over 50 years old. It's upstairs. There's no real access to outside space, and there's little we can do to further improve the facilities. Or Albany Lodge in St Albans, again, that's 25 years old, and it's a standalone facility. You can see that there's some significant levelling up for us to do. We also have significant pressure on bed demand, and I think we've talked about that here previously. And that means our wards, when they're full, which is much of the time, some people are placed in the independent sector, and again that can be some distance from their community, and all the modelling looking forwards demonstrates there's going to be an increasing demand for mental health provision and for bed numbers. So all of that really impacts on service user, carer and staff experience, and brings into question to a degree the long-term sustainability of the current arrangements. So we're starting to explore how we can address the inequity of both access and of environmental quality, with the potential to build a brand new state-of-the-art facility serving East and North Hertfordshire, and to also arrange access to beds for residents in what we would call the far east of Hertfordshire, and we're exploring arrangements with our neighbours at Princess Alexandra Hospital to see what that might look like, but also to increase the total number of beds that we have available so that we've got a significantly improved and sustainable position moving forwards. Our early thoughts are given the population and the patient flows, that Stevenage appears to probably be the most appropriate location. It's also worth saying we've spent nearly a decade looking for an appropriate site, so it's not been an easy job, and we've certainly worked with your colleagues in the local authority to see if there's anywhere we could identify, and we think now is the right time to start to progress. I'll stop there. I'm going to hand over to Dr. Farrow, who's going to give a little bit more detail about the clinical and the quality aspects.
Thank you. And can I just remind everyone really that I'm under a tiny bit of time pressure.
Oh, apologies.
So, yeah, no, you're okay. Listen, this is a good news story. So, there's no question about it. It's a good news story. It's a win-win situation. So anyway, over to you, Joanna, and to hear from what you have to say. Thank you.
Thank you, Chair. So I'm Jo Farrow. I'm the Clinical Director for Acute Services, and I myself work as a consultant psychiatrist in Albany Lodge. And we really want to improve the care that we provide for our service users, to improve the experience and to improve the outcomes, and to improve the support and experience we can provide for our carers, and to improve the working conditions and environment that our staff work in. And we know that we can't do this in our current units in Aston and Albany Lodge. Standalone units, with the increased acuity and demand that we're seeing in our acute units, are not how we want to deliver care for our service users in the future. We need to have units that are part of a larger mental health unit, so there are larger numbers of staff and resources available to allow us to safely respond to mental health and physical health emergencies. And the Royal College of Psychiatrists, in its standards for adult acute inpatient units, it stated that 18 patients is the maximum that we should have in one ward. And currently we have 24 beds in Albany Lodge and 20 in Aston Ward. So thinking about the benefits to our service users, so we want all service users who need inpatient care to be in an environment that we currently have on offer at Kingfisher Court. This includes having ensuite bedrooms, which allows our service users to have privacy and dignity, and to have single-sex treatment wards. We want to have good outdoor space with gardens, courtyards, which is very therapeutic for people who are receiving inpatient mental health care. We want to have safer environments with less noise, less overcrowding, and safer environments on the ward. A new unit would allow us to have a full range of facilities for occupational therapy, for psychology services, which would allow our service users to have groups and to have sessions, to have an assessment that we're not currently able to deliver in Aston Ward and Albany Lodge. A new unit would also help us to work with our service users to improve their lifestyle. For example, being able to offer them freshly cooked food, gym facilities, and have access to grounds for outdoor exercise. It'd also be much less disruption and travelling for our service users, because currently people are admitted to Swift Ward, and then they may then be transferred to Albany Lodge or to Aston Ward, which can be a long way from their home. And as Keith said, we want to increase our bed numbers so we no longer need to use out of area beds, which can often be outside of Hertfordshire. We know that if we have a new unit, we can achieve better outcomes for all of our service users, like we're currently able to do for those that we offer care to in Kingfisher Court. The benefits to our carers would be that we would be able to offer them a welcoming environment for when they're coming to visit their loved ones who are in hospital. We plan to have a cafe with large spaces where they're able to meet and to visit their family members. This would also allow them to have their children to safely visit, which is really important when someone's in hospital. For our staff, we know that a new unit would offer them a much better working environment. It'd be safer for them as they're having increased resources around, and also offer a better ward environment. Having a maximum of 18 patients on one ward would allow much better staff and service user engagement, and also allow the staff to feel less isolated and part of a much larger hospital team. Hand over to Sandra now. Thank you.
Thanks, Jo. And Chair, obviously I'll take the point about time. So I just really wanted to summarise a bit about the stakeholder engagement. So to really assure the committee that throughout our planning so far, we've been working really closely with our experts by experience. So that's service users and carers. So they've been really involved, particularly obviously in the initial design proposals. We will continue to do that throughout the work. They're also members of our project steering group and different work streams. And that's been really important in actually hearing their views, and their views have been very much listened to in terms of the design of the building and the way the building would work. We're now in the part of engaging much wider with wider communities. So that includes our service user and carer councils, other forums. For example, we've met with Carers in Hearts. We've got a series of dates over the next couple of months to have further conversations with CCGs, with other system meetings, other system partners and local patient groups. So we'll be doing that throughout the rest of December and into January. And that's really to hear the views with a real opportunity to look at our proposals and say alter the design in response to that. And there's been some really good feedback that we're already working on, and we're going to do some specific works. I know one of the things is very much around carers and visiting facilities. So we're going to do a specific piece of work with carers around how that will look. So we're really keen to do that. We're really keen to continue that partnership working and respond to that. We also have planned on the 18th of January a virtual tour for the Scrutiny Committee, and that will enable you to hear from service users and staff around the plans, to have a much more detailed view from the architects, designs, etc., of what the unit would look like. So I'll leave it there, so conscious of time, but so just to assure you that, you know, we've got a lot of engagement planned, and that's an important part of the journey that we're on. Thank you.
You're on mute, Chair.
Apologise again. Roma Mills is the first one I've got on the list, and I've got Maureen McKay there who wants to speak second. So Roma.
Yeah, thank you very much, Chair. Certainly welcome news about more beds, more inpatient beds coming into play in Hertfordshire, because I think even back in 2015, many people external to the Trust were not confident that the reduction in beds that was proposed and was introduced then was really going to meet the needs in Hertfordshire. And since then, and indeed even before then, we've seen bed occupancy rates way above the recommended levels of the Royal College of Psychiatrists, with people placed often at great distance from home. So yes, really pleased to see that finally the idea of having more beds in Hertfordshire is coming forward. I do have to comment on these proposals, and I was aware of them in fairness because Sandra Brooks had briefed me on them some months ago, but I do have to comment on them because we've heard Keith Loveman saying we have to improve, we don't have equity of provision across the county, but that was recognised back in 2015. So when in 2015 there was significant consultation across Hertfordshire, many carers and service users only signed up to the large development at Kingfisher Court on the basis that there would be an inpatient service in Hemel Hempstead, a new one. There would be a new inpatient service in Stevenage because no one thought Aston Ward was fit for purpose. We acknowledged that those two new developments would mean Albany Lodge closing, So no one thought Albury Lodge and Aston Ward were the services going forward. And we were also in discussion about having a service in South East Herts, which is poorly served in terms of inpatient service. So, we were not expecting the current configuration of services to continue. And I have to repeat again, the development of Kingfisher Court was predicated when people only signed up to it on the basis that there would be other local inpatient units. So I think that has to be stated, because this will cause disappointment. I note the comments about stakeholder engagement, but most of the engagement has come forward once there's a very clear proposal on the table. And I think this is what's so difficult for people external to the trust. Co-production is about involving service users, carers, voluntary sector stakeholders, and everyone else from the start, not when a proposal has been worked up. And whilst I'm pleased to hear that service users and carers are involved in the design, the proposed design, we need to go back from that and have that discussion about why the proposals that were agreed previously have now gone. Now, we've also heard this issue about potentially having beds in Princess Alexandra Hospital to serve the southeast of the county. But when I put that question to the chief executive from PAH, he said, well, there wasn't even agreement as yet that there would be an inpatient mental health unit on that site. And I know there isn't yet. Now, Sandra's predecessor, Jess Livesey, was talking to me about using Princess Alexandra Hospital, and that must be 3 years ago now. So, we hear these things and it all feels a bit like deja vu. I know the Trust is committed to providing the best high quality inpatient safe services it can, but to be honest, we keep seeing these changes brought forward that people haven't signed up to. And it does make it difficult for people to be confident about the reality of the engagement that goes forward. Kingfisher Court is now described as the service that serves the west of the county. It's very much in the centre of the county. So just as it's been difficult for people from Bishop Stortford to get there, it's equally difficult for people from Tring and Berkhamsted and Three Rivers, and who are being placed there are then equally cut off from their communities in the way that people from Bishop Stortford and Stevenage are if they have to go all that way down to London Coney. So whilst I welcome the beds chair and I welcome the hope for a new purpose-built service, I do say please take people with you, Trust, at an earlier stage, not when you've got the proposals on the table. Thank you, Chairman.
Okay, colleagues, I think Roma's plea is fairly well said there, and I don't know if the Trust wants to comment, anyone from the Trust wants to comment on what she's been saying. It is common sense that you take people along the journey with you rather than bring them in at the end. Does anybody want to say anything from the Trust?
So I'll just come in very briefly, if I may, Chair. And I think Roma's points are well made. There's not a whole lot there that we would look to disagree with. I think she's right, and I agree with yourself. Let's make sure that as part of this process we do properly engage with people, and I think that's part and parcel of the reason that you've invited us here today, really, to make sure that happens.
Okay, I'm sure you've taken on board all she said. So now the next person I have on the list is Maureen McKay. Maureen, would you like to turn your microphone and camera on and fire away?
Okay, thank you very much. Thank you very much, Chair. I would actually like to mention the fact, it's a great presentation, and I particularly like the bit where it said keeping people close to their communities. I was also involved in a visit to Watford in the provision for young people. And the bit that I find missing here, and it may not be part of the remit, is what provision is there for young people in North Herts? When I visited Watford, I was really impressed. So I wonder if I obviously welcome the news at 54 more beds, but what provision is there for young people with mental health problems?
Okay, who's going to answer that, Sandra?
Yes, thank you, Chair. I'll answer that. So thank you for that question. So we will continue to provide, we have an adolescent unit for 16 beds, which is based on Kingsley Green for the whole of Hertfordshire. I will continue to provide that service, and in fact we're about to look at refurbishing the unit and including 2 additional high dependency unit beds, which actually will really help to enable us to keep young people in local services. So that actually would appear to be the right sort of number for our young people and adolescents currently for acute care. What we have done over the last couple of years is actually really develop our community services. So we have a well-established home treatment team and DBT team for our young people. So we believe at the moment in terms of acute care, we have sufficient facilities. And obviously we've got extensive community services across the whole of Hertfordshire that support young people.
Thank you for that, Sandra. Now, we now have Margaret. Margaret, are you there? You're the final question there.
Yes, I'm here, Chair. Sorry, I just pop up.
Carry on. Yes.
I'm very interested in the joined up care of mental health patients, and I'm interested in the transitioning and how we're thinking not only of the inpatient care, but how they then transition back into community afterwards, and whether alongside Kingsley Court you're thinking, and whether we work with the local authorities for sheltered housing when it may not be appropriate for them to go back into the same home they may have come out of.
Sandra.
Thank you for that question. So ongoingly, we are really looking at our options as to how to step people down out of acute care. We are working really closely with our HCC colleagues to look at some further expansion of step down from acute care. We know how difficult it can be at times to enable somebody either to go back to their own home or a placement. So we're working on a range of things that might be actual step down 24/7 care, or it may be more supporting facilities. So we're in current conversations around that. And again, to enable people to stay more in Hertfordshire and not have to go out for that type of care. So that's very much part of the pathway that we're developing alongside our acute care.
Thank you. Colleagues, I've got no more hands raised on my chat box, and so therefore I'm going to ask you if you agree the recommendation at 3.1, 3.2 and 3.3 in the report. Can you vote now in the chat box? Michelle, can you tell us when we get to a majority?
Majority agreed, Chair.
Yeah, that's fine. So that's carried. Okay, so what I'm going to propose now, before we move on to agenda item 7, is actually have a break now, because agenda item 7, there's quite a bit of quite a few slides here, so I didn't want to overrun and we're ending up having a break in the middle of something. I think if we do it now, it would be a lot easier. So I'm not too sure how all your colleagues feel about it, but I'm going to suggest a 10-minute break now, because we're breaking a bit earlier than the one I mentioned earlier on in the beginning of my notes. So if we have a 10-minute break now, so if we call it 11. If we come back at 11, what would that be? 55. Can we do that? Is that possible?
11:55, Chair.
Yeah, I think that's fine. That's enough at this stage. So then we can crack on and hopefully get things done before a late lunch sort of thing. So there we are. So 11. So we'll stay online, turn your cameras off, and we'll come back at 11:55. Thank you.
We're now live, Seamus.
Thank you, and welcome back, colleagues. We are now at agenda item 7, which is the Integrated Care System update. And what I'd like to do before I invite the relevant presentation to take place, I'm going to invite Natalie Rotherham, our Head of Scrutiny, to come in and say a few words.
This is just a few quick words because the committee has heard quite regularly from the ICS in terms of development of the ICS and the integrated care partnerships within that. And the pack that you've got from the ICS gives a response to a number of queries that were raised at previous committee meetings. So rather than labour through what is a very extensive set of slides with an awful lot of detailed information, I think what the chairman would prefer to ask ICS colleagues on behalf of the committee is that there's a kind of, as other colleagues have done earlier in the meeting, is that it's the headlines, particularly of new information, and following on from the last item, the developments around the mental health integrated care partnership. I know that's an evolving partnership, but it would be helpful for members to just get a sense of how that is developing and what might be included with that. I hope that's okay with colleagues who are in attendance from the ICS. And back over to you, Chairman.
Yeah, okay, that sets the scene quite nicely. So we're looking at this as a highlighted view on this particular one. So over to, is it Jane, are you presenting?
I am. I'm slightly confused by Natalie's introduction because I had understood that the prime ask was to update on what was happening to support staff wellbeing across the ICS in the light of the earlier committee discussions around COVID response earlier in the year. So I simply have a few short slides
Okay.
on those. Which,
well, let's do it. That's fine. If you do, you can carry on the way short slides on this. But I think what Natalie point we were making really is that there are a lot of slides here in this document, and we would be really pushed for time if we were going to go through each and every one of them. So if you could pick out highlights.
So I was simply going to speak briefly to the 9 slides in item 7. There are other slides included for background detail.
Let's just do it so we can get the time done. But we're under time pressure. Okay, the 9 slides.
So we, as I've just said, we were asked to update members on how we were supporting NHS staff across all of the organisations in the ICS in recognising the pressures that staff have been under now for approximately 10 months and will be under for some further time. So we've drawn out a few specific aspects of that to just give hopefully a rounded and holistic picture. If I start with sickness absence on the 3rd slide. This is obviously from a couple of weeks ago when we pulled the pack together, but these figures would remain broadly similar at the moment, showing that at any given time we're seeing approximately 5 to 6% staff absence across the board, around about 2 to 2.5% of which is associated with COVID. Now some of that is staff who are unwell with COVID, but it also includes the impact of self-isolation through contacts and including where there's other family members as well as through work settings. The second thing we thought might be helpful to draw out is in part how we try and prevent staff becoming unwell. So you have in that first slide deck the position on flu vaccine uptake as it was at the 20th of November. Now all organisations that are listed in that chart have made progress since then. Princess Alexandra Hospital in Harlow does remain actually at the top of our list having gone up very slightly from where it was, but rates at West Herts Hospital Trust are currently around about 79%, Herts Community Trust at 80%, Eastern North Herts Trust 67%, HPFT at 71%. So as well as everything else, we are trying to ensure that our staff are protected against those illnesses we can protect them against, and obviously we know that at the moment we are in the early stages of rolling out COVID vaccination across Hertfordshire, which will be relatively prioritised towards NHS and care home staff as well. We have taken a very consistent approach to identifying and trying to support those staff who are at higher risk from COVID, often because of their ethnic background in particular, but there are other factors that are taken into account when we do risk assessment. And we use that risk assessment in order to develop a variety of different ways of mitigating that risk, reflecting the fact that employees might be at risk of COVID from their ethnic background, but actually if they are in a type of job that they can do quite safely from home, then clearly that manages the risk. That's quite different from those staff who are in frontline roles. So just to sort of draw out that those responses are different depending on the different roles staff are undertaking. We have continued to provide additional training on a whole range of issues, particularly effective infection control and use of PPE, and that is a very extensive offer, including all aspects of primary care, care homes, and increasingly domiciliary care settings as well. And then as a more general aspect of supporting our more vulnerable staff, we have put a lot of effort right the way across the ICS and within the individual organisations to having a robust set of staff networks where staff can come together to support one another, where those networks can generate greater awareness of the additional areas where we need to focus on in terms of further training. For example, in terms of the overall approach to supporting staff wellbeing, we try and take a really very comprehensive approach set out on the following slides schematically, thinking through all aspects from ensuring that staff are led and managed with compassion, are encouraged to take active steps to maintain their own health and well-being, right the way through a sort of an escalation, if you like, through provision of employee assistance support, and again that support offer has been extended recently to include primary care as well, right the way up to staff who may need dedicated and specialist support with their well-being. Linked to that overall sort of pyramid, just to draw out on the following slide some of the specific elements that take place as part and parcel of this work. So in terms of at the bottom of the pyramid, what do we do to sort of try and build in awareness of health and well-being? Some of that is around encouraging those staff that can take breaks to do so, reminding staff to use their annual leave at the moment, the importance of taking breaks, being refreshed and revitalised, even where there is limited opportunity to go and have a holiday as we might have done. Other steps include creating time and space for staff to reflect together on the emotional consequences of what they're dealing with at work, and to debrief and decompress, and not to bottle things up. I've touched on the employee assistance programme, and also the bespoke support in terms of occupational psychological support for those staff that need specialist input. Lastly, we recognise that supporting well-being of NHS staff is in part contributed to by a much broader range than just within the NHS family, as it were. We have seen moves towards much clearer collaboration to identify where we may have additional staff to draw on, particularly in relation to things like the rollout of the COVID vaccination programme, including staff who may be furloughed from other industries but have customer services and customer contact experience and skills. We have had and continue to have an absolutely fantastic response from third sector partners in terms of volunteers stepping forward, but also the innovative ideas that come from those organisations right the way across the county that are also part of supporting delivery of care and therefore taking some of the pressure off our own staff. We know that that is a particular strength being drawn on as part of the vaccination planning, and the last bit I thought it was just worth highlighting was the mutual aid arrangements that we have in place, so that organisations are supporting one another rather than sort of trying to consume their own smoke. So Chair, that was really all I was going to talk to. Like I say, the other information is included in the pack simply in case members had further questions about the detail.
Oh, that's great. I'm sure members have read the pack and it's very, very detailed and comprehensive, without a doubt. I've got a couple of people want to come in straight away. Ron Tyndall. Ron.
Thank you very much, Chair. Hello, Jane. I'm very interested in the annual leave aspect. I've always think that with the workforce, particularly a larger one, the uptake of annual leave is a very good indicator of what's happening within the workforce. And are you keeping a very close eye on people who are taking their leave, how much people have got left over, what's your carryover rate, and how often are you having to ask people to forgo leave because you're running staff shortages?
Excuse me. So we are, as I said, actively encouraging and monitoring utilisation of annual leave, although that monitoring is done in the main within the individual organisations. We have been encouraging people from really the early days of dealing with the first wave of the pandemic to continue to take leave. Initially, there was I think a higher level of reluctance, both in terms of the nature of the lockdown at the time, but also a sense of guilt of not being at work if others were. We've seen that mitigate a bit as time has drawn on, but it's then become a little bit harder to encourage people to take leave when, put bluntly, there's nowhere to go and not a lot to do. But it is, as I've said, important for well-being to have time to breathe and to think. We are not in the main asking people to massively alter leave plans. There will be department by department, there will be some changes as pressures come and go. But we absolutely recognise the importance of staff having time to themselves, time with their families. So we're pretty confident that the systems that are in place are an appropriate balance of ensuring staff well-being with ensuring service continuity.
Thank you for that,
Can I just add, sorry, can I just add that for me in the past, it's always been the last quarter of the leave year, which can creep up on managers unexpected, and you suddenly find your horror that you've got a vast amount of leave that's not been taken for very good reasons, and then you suddenly have to divert resources to manage your way through it. So I would advise that, within all your systems, that you keep a very good eye on as you enter the last quarter of the leave year, exactly what your leave position is, because it can actually cause immense problems. Thank you.
I think Jane will hear what you say, as they say, and we'll keep a very close eye on it for you, Ron. If we can move on now to Maureen McKay. Maureen.
Okay, thank you very much. Thank you, Chair, and thank you, Jane. I was particularly looking at your the percentage for East and North Herts for the flu jabs, which was around 67%, and realising that it's in order to get a COVID vaccination, there needs to be a gap between that. So it bothers me that that we need to increase this flu jab number, inclusive to make sure that the vaccination programme goes ahead to safeguard our staff. Okay,
that's a good point. Jane, your thoughts?
Yeah, so we work really really closely with provider colleagues to try and encourage and maximise uptake of flu vaccine for its own sake, and indeed this year in particular for the points that Maureen has made. I don't know whether Sarah Brierley wants to come in, particularly in terms of Eastern North Hearts Trust figures and if there's anything sort of particularly to add, but certainly we there are regular weekly reviews and feedback loops with the data being fed round and people being chased down as actively as possible.
Sarah, we're going to invite you back in. Your figures don't look good, so any ideas how to get them up?
Yeah, they could be better. I absolutely agree, and the board are disappointed they are not as high as we would like them. There's been a phenomenal amount of work that's gone on trying to encourage staff, and that will continue, and it is continuing. Culturally, as an organisation, Eastern North Hearts Trust seems to have a lower uptake over the years of flu vaccination. It's not that it's dipped this year. It is broadly in line with where it was before. And we are continuing to push that really, really important message about this is about protecting our staff, protecting themselves and their patients, and also encouraging uptake of the COVID vaccination. So I share that concern. It's something that we are very cited on and are continuing. It's not mandatory. So we have to do everything we can to encourage and support our staff to choose to have the vaccination.
Okay. All right. I think we might be coming back to this in the future. I can see
That's
that
fine. Yeah.
Because it is very important that we're trying to encourage everyone to have flu jabs that's offered them, and it's very disappointing when a large number of staff don't take it up for some reason, whatever that is.
Yeah, I agree.
Yeah, we need to look at this in detail, because with the COVID-19 vaccination, it would be really, really disappointing if we saw figures like this in coming out. But there again, it's too early to tell. Yeah. Okay, so I've got one other person. Ron wants to come back now, as he raised it in the first place. He just wants to come back again. Ron.
No, thank you. It's just on this business of the flu jabs. I wonder, has anybody carried out any correlation between the percentage of take up on flu jabs and the instances of sickness within the different units? And to see whether or not that is actually the low take up rate is actually increasing the level of sickness.
So as it stands at the moment, we're not in what we would normally call peak flu season. So we typically see the highest rates of flu-related illness and sickness absence in the months of January and February, which is why we push hard to get flu vaccination done in the autumn before high levels of virus are circulating. So the point in the year at which we would look for that correlation, Ron, is actually probably at least another month to 2 months away. As it stands at the moment, the higher rates of sickness absence have tended to be where in those hospitals that have seen the highest numbers of COVID patients being admitted, rather than flu. So I think there's a timing issue, but I'm happy that if as Seamus has indicated, it's something that you want further information on, we can certainly look at that and bring it back later in the year when we've got those time sequences.
Yeah. Thank you very much.
Okay, thank you. I've got no one else to ask to speak. So can we note the report, please? And we can agree that in the chat box. So just... Michelle, are we getting near a majority?
Yes, Chairman, majority agreed.
Okay, thank you. That's agreed then. So we move on to agenda item 8, which is the Black and Asian, the blame update. Who we have here? We got Faisal.
Thank you.
Would you like to report in?
Indeed, thank you very much, Chair, and good afternoon, councillors. So this is a short update following Jim's presentation back in September, Health Scrutiny Committee. I'll take the report as read, but what I'll do, I'll just highlight some of the key work that we've been doing in the Black, Asian, minority ethnic communities during the pandemic, during the different waves during the pandemic. So just to, in terms of the background information, you may recall Public Health England carried out a report during the first wave of the pandemic that highlighted Black and Asian minority ethnic people could be more susceptible to getting COVID. And some of the issues that was highlighted in the report is one, that BAME individuals tend to be more on the front line, but also there's social structural determinants such as health, socioeconomic, occupational, structural factors that could be one of the determinants, that reasons why BAME communities are getting COVID more than others. So back in March, we set up a community reassurance cell that was made up of a number of district leaders, and that was to look at the medium to long-term impact COVID was having on our communities. We sent out a survey, and what came out very strongly was the need to support more BAME communities during the pandemic. About the same time, we developed an action plan, which had 4 key work streams. One was prevent and protect, second was communications and behavioural science, thirdly was high risk reduction, and last but not least was to co-create a medium to long term action plan. So in terms of the work that's been carried out thus far, so we've established a Black and Asian minority network, which is community-led and co-designed with the community and public sector. The purpose really was to set up the network. There was a need for an infrastructure for Black and Asian minority communities and residents. So there's a central point where we, public sectors, alongside community groups and CVS, can discuss the issues that have been highlighted, not only through the Public Health England report, but what was being said on the ground within Hertfordshire. We carried out a webinar back in October. We had arguably a good turnout. This was chaired by Councillor Linda Hazy and others on panelists on the panel, starting the discussion around health inequalities within the Black and Asian minority ethnic community. We've also produced a number of videos and guidance in a number of different languages. There are links to those at the end of the report around social distancing. I think what we found is that the main messages needed to be adapted slightly to make them culturally appropriate to our targeted communities. So we continue to do that. Smoking cessation was increased for BAME communities. We also had infection control guidance for BAME taxi drivers and PPE with that as well. We've been working very closely with the interfaith forums in the county. So the Herts County Council, there's a county-wide district forum, and as well as that, there's district interfaith forums as well. And they've been really key in terms of getting those messages out. So in terms of the medium to longer term activities we've got planned, we want to do a series of webinars. So the opening webinar that we did back in October highlighted the need that we need to focus more on specific areas such as mental health, financial hardship, signposting, education as well. Linked to the 2 areas that I just want to highlight was, one was around the inequalities and outcomes review from the Public Health England report. So this is something that we're quite keen to progress, which is essentially looking at what was said in the Public Health England report and how does that reflect in Hertfordshire. So that will be a systems review. More targeted communications. I think we're realising the power of community people talking about the issues within the community. It has more resonance. More BAME capacity building. So the CCG are looking to fund 2 BAME capacity building officers that will be rooted in the community. That will help to build that capacity. And last but not least, we're also looking to recruit a specific BAME COVID project manager stroke coordinator to develop the action plan further and put a framework around it as well. I think, Chair, that's it for me, but I have to take any questions. Thank you.
That's great. That's very, very comprehensive. The only question that I could think of, you were talking about doing a series of webinars. Could you give us an indication roughly when you're thinking of starting them?
Yeah. So the first one we're planning for the end of January, early February. And then we want to get into a place where we're doing one every 2 months, and I think it's ensuring that we do the webinars that have the right message and key around education. I think that's the bit we're trying to bottom out. So to ensure that it is meeting the needs of what the community is asking us to do.
Yeah, I'm sure that you know, it goes without saying there that when you have all these details up and running, you can contact Natalie and give her the information as well, so we can broadcast it through all our health colleagues as well, so as wide as possible, because I think that's quite good to do. We don't seem to have any questions. I think you appear to have done such a good job that everyone supports your work, and they've got I shouldn't have said anything. I've got Natalie coming in first and then Margaret.
It's just to say to Faisal, he won't be at all surprised that obviously the other committee is also deeply interested in this work. So my suggestion is that this report is shared with OSC, and then any further information that Faisal sends me on behalf of this committee, I will also share it with OSC, so that that information is getting to both sets of councillors.
Okay, thank you for that. That's a good idea. Margaret, you wanted to say something.
Thank you, Chair. And thank you, Faisal, for your report. One of the things actually in the discussion, it was in the overview and scrutiny joint sessions, was particularly which Black and ethnic minority workers may not have come forward and been tested during the summer and actually even now. And how much having a buddy who could be an advocate for them could actually help in communication. You put a section on communication and behavioural science. I am just aware just the sheer number of Black and Asian care workers there are, and domiciliary workers in the health service and in adult and social care. And I happen to be at the moment caring for my mother because my sister's had to self-isolate, so I'm actually not where you think I am, but I am aware that the carers that come to see my mum are tested every week, but not every care agency is doing that, but they are entitled to that. And just making sure that all Black and ethnic minorities who are really on the front line really get the testing that they require, and in the future vaccination, of course, as well.
Yeah. Thank you, Margaret. I think that's I can take a point up with our Director of Adult Social Care, Chris Badger, and find out what is the current status in terms of BAME frontline take up of testing. I should also add, sorry, I should also add, we are doing some work with the behavioural science team in public health to look at potential, I suppose, looking up the vaccine take up from BAME communities. So they are carrying out a piece of work to look at previous take-ups of vaccines from BAME communities, which at the moment is looking less than the wider population. We don't exactly know why. It could be a slight mistrust within the NHS system. We're unsure. So we are gathering that information at the moment and seeing whether we need to do any targeted communications with BAME communities, particularly around the vaccine take-up.
I think that's a really good suggestion. Thank you for raising it, Margaret. I mean, the buddy system, I think it's really important that as many people as possible are vaccinated against COVID-19. Otherwise, the immunity level across the country, it'll take a lot longer to clear this virus. It's the only solution we have. So we wish you good luck with that working. And while I'm mentioning that, I wish your sister good luck in recovering from her isolation as well, because it's not easy. I know people that have been in that similar situation. And it does affects many of us in different ways. It's not the easiest thing to be doing. So we're asked to agree the report. So can we in the chat box agree it, please? Oh, we've got one more. Ron has just come on my screen. Ron. Yeah. Sorry, Ron.
That's all right, Chair. I had to chair a meeting a little while ago, and I found it such an immense task that you're doing a fantastic job.
Oh, I wouldn't say that, Ron. Is this before an awkward question comes?
No, Faisal, I just wondered, having reference to the last item, have you got any figures on the take-up of the flu vaccine, flu jab, or for the BAME community? Oh, I hate that word. Black and Asian minorities community, because I wonder whether or not, again, I'm looking for possible correlations, and if people are avoiding the flu jab, will they then actually not be too keen on the take up of the vaccine when their turn comes, and that could cause us problems.
Thank you, Councillor Tinswell. Yes, I think, like I mentioned in previous response, there's the behavioural science team in within PH are looking at data at the moment to ascertain whether BAME take up is less when it comes to vaccines, and I think they're going back to look at H1N1, but I'm happy to pick that up with the public health team to get some that hard data, maybe, is what you're looking for.
But I think it's really looking for information that can advise us and guide us going forward, because if we can pick up any pointers from recent past on such things, it may help us how we deal with issues going forward, and it all links in together.
I did see Tim Hutchins, the cabinet member responsible for public health, on the line earlier on. Hopefully, I don't know if he's still here. I'm sure if he hasn't, we'll ensure that this is brought to his attention, because I think it's something that everybody needs to be watching to ensure that that the COVID-19 vaccine does go as widely as possible to our residents, but also the flu jabs. It's something we're going to have to work on, Ron, I think. But I think it's a very good suggestion that we monitor this.
Yeah, I think you see your words are like wisdom. Tim's just popped up.
Has he popped up?
Yes.
Is he there? Yeah. Did you hear what I just said?
Yeah, if you don't mind, Seamus. I mean, it's very early days.
You've got a couple of minutes. I think it's very important that you come in now. You can give us a brief update of what's going on as far as you view it. Yeah.
Yeah, I don't have fine detail, but what I would say is that it's very early days. They started the programme last week. My intelligence thus far is that it's moving very smoothly. But I think it'll be a couple of weeks at least before we start getting the fine detail and knowing about who's accepting what. But I think we're all perfectly very aware of the risks of people getting fake news and fake information, the risk of not enough people getting on board. So we are monitoring it very, very closely, and we'll obviously act accordingly. As I say, thankfully at the moment, I think it's going quite well, but no doubt there'll be bumps in the road as we go along.
Yeah, there always is, and I think it's thank you for that bit of an update, and I dare say you'll be updating all the councillors, and we can, and ourselves here. We can share your emails and what you say in press releases. Natalie can share them to all the members of this committee and every other committee in Hertfordshire to make sure we're doing everyone's aware of what is happening, because the last thing we want to get into a situation is that a particular group or sector or whatever aren't picking up this the vaccine. It's important. So thank you for that, Tim, that update. And Faisal, I think we're at a situation now where I can go back and ask everyone to agree your report. It's very comprehensive. It gives us a good indication of what's happening. And as you say, you'll be starting your webinars in January. So we'll hopefully click onto them. So is everybody, Michelle, you can tell us when we get to a majority. It's all going blue, so that's good.
Majority agreed, Chairman.
Okay, well done everyone for that, and thank you, Faisal, for all the work you're doing. It's very important, and we wish you well in continuing it. So if we now move on to agenda item 9, which is the Scrutiny work programme. So this is our work programme moving forward, and we've got Fiona going to present it, I understand. Natalie is here as well. So what will happen for the first bit anyway is Fiona will do her bit presentation, and then maybe Natalie might want to come in and get it up as well, just to make sure that we've covered everything that's on the recommendations 1 to 7. Okay, Fiona.
Thanks, Chairman. Yep. So this is your, the usual Scrutiny work programme report, and you've got outlined in the report all of the work programme items that fall across both Overview and Scrutiny Committee and the Health Scrutiny Committee. But obviously the ones that you have the opportunity to comment on and to make decisions on are the ones that relate to the Health Scrutiny Committee and its remit, which is outlined in the work programme. And within the report, what the parts to highlight really are the the scoping document, that you have one scoping document there to consider, which I think Natalie is going to talk about in a little bit more detail, which is the West Herts Hospital Trust Health Infrastructure Plan topic group. And I think Natalie also wants to talk a little bit more about the Drug and Alcohol Services Seminar, because we've moved on a bit in the planning of that now. So we'll have a bit more to tell you about for that one. And so the other thing is just to note that obviously now at the committee today, this is your chance to to comment on anything to do with the work programme, make suggestions for topics that you want to be added to the work programme, and talk about prioritisation. I think it's important to note, if you are looking to add items to the work programme, think about whether it's something you just want a quick bulletin, or whether it's something that you think really warrants a topic group. And obviously keep in mind that the length of time needed for planning and resource to support those things, because at the moment we have got quite a busy work programme planned, and so I think if new items are going to be added, they have to either be further ahead down the line in terms of time frame, or you have to look at reprioritising. So just to keep all that in mind, and that's all I wanted to say. Thanks.
Natalie, do you want to come in before we open it up for discussion?
I think if I might, Chairman, that I think would be helpful. I want to start with the most recent item, really, which was a suggestion at full council from Sharon Taylor about the impact on treatment for illnesses other than COVID. The example she was thinking about when I corresponded with her after the meeting was she was mentioning cancer and renal and cardiac. I've gone back to Sharon and I've drawn to her attention that you will be undertaking the patient outcomes and experience scrutiny in March, I think, which is an ideal way with the questions that you've got in the pack to actually get information around what's happening with backlogs and waiting lists on some of those non-COVID incidents. However, if it appears that you're not able to get the level of detail that you think is important to have, excuse me, I would suggest you potentially put that on the work programme just to see if it's addressed by patient outcomes and experience. You take it off because it's done business. But if you think it needs a focus, perhaps at a committee meeting in the way that you've done some of the other things recently, you can pick that up there. So that would be my suggestion of an item that it's been suggested the committee give some attention to.
So you're suggesting we put it on the work programme now, and then in the event that it's covered in March, we'll take it off.
Yeah.
Okay, that's a good idea. I strongly support that. Yes. So thank you for that. Let's just remember when we're saying, yeah. Oh, okay. Carry on.
Oh, there were a couple of other things, unless it was you were wanting to. Is that okay?
No, carry on.
In terms of substance misuse, members will remember that they had drug, alcohol and drugs strategy on the work programme as a topic group pre-COVID. And as Fiona has said, we've been working behind the scenes to look at some of those items that were on the work programme and see whether they can be delivered differently. We've spoken to the lead officer for this item and she is strongly of the view that she can reframe it as a seminar. So it won't be a scrutiny, it will be an information item. But I think what it will do is will give you as councillors the kind of information that will assist your work locally with local stakeholders and community groups and possibly individual residents. So we're working on that, and the provisional date for that is the 10th of March starting at 2 o'clock, and it will follow the usual format of a presentation followed by councillor questions. And Fiona has sent out already a hold the date, and as we get more information about the detail of the seminar, we'll clearly make sure that that comes out to you. And then just moving on to the West Hart scope, I think it's worth reminding ourselves that amazingly this integrated care system, the ICS, two of its three acute hospitals are in the first wave of the health infrastructure programme, Princess Alexandra and West Hart. And it's the members may recollect that back in May we were invited, this committee rather was invited to join with Essex to consider the proposal for Princess Alexandra because 50% of the patient flow thereabouts to Princess Alexandra is from Hertfordshire, so clearly a very vested interest in what happens at Princess Alexandra. So when we were developing the scope for Princess Alexandra, due to the similarity of the two HIPs, the Health in Infrastructure Programme, the similarity of those, it was decided for consistency to use the same questions across both scrutinies. And officers of the this committee and the NHS are working on the programme for the date, which is now scheduled for the 1st of February 2021. Just a reminder that the rationale for this taking place a bit later than we might have anticipated was the outstanding JR, and now that we're at the position of waiting for the judges judgment, we're now able to progress on that. So the committee is asked to actually agree the draft scope that it has in the pack. And then my final one, Seamus, is around patient quality. The format and the questions are contained in the pack. The questions, you'll note, have been rephrased and further developed from previous years to reflect that COVID impact on services, which Sharon was articulating at full council as something that councillors are concerned about. Those questions have been shared with providers and in fact further strengthened to ensure that the response that you get is robust in terms of the feedback, and that you're able to get the level of detail to enable you to drill into the issues that are necessary. We will be following the same format as previous years, which is where each organisation will be considered by a separate smaller group of members led by a chair who will organise the key lines of inquiry and make sure that you cover all that is necessary in that time. Just as a bit of assurance, because it will be the first time that we've done it virtually, we will be looking at any experience that comes out of the IP budget scrutiny in January, in case there's any tweaks that we need to make to just make sure it runs as smoothly as possible. So those were my comments, and I will finish there, Chairman.
Thank you. I have some people already indicating they want to speak. I've got Ron Tyndall, Margaret wants to have ask a question as well. I think I've got Jane Halpin's hand up as well, but I can see on my screen that Helen Brown has just joined us. And I'm sure, Helen, did you want to? I'll give you the opportunity now, and thank you for being here today. I give you the opportunity now of actually saying something prior to the questioners, or shall we hear all the questions and then you might want to react to them?
I'm happy. Thanks, Seamus.
Yeah.
I'm happy just to answer questions. I think Natalie gave a good overview, so we'll just pick up from there.
Thank you. I think Natalie's overview, particularly regarding the scoping documents, is a correct and sensible way of dealing with them, which would be, in other words, that we're dealing with both of them as equal, the same. They'll be the same. So we're not taking priority over one or the other. They will both have the equal situation with them. Now, Ron Tyndall has come in, and Ron's got his camera on already. He's raring to go. Go on, Ron.
Thank you very much. I'm going to speak to the scoping document 2A, and Natalie did mention the judicial review, and of course the fact that happened has delayed the whole process, and so some of what I'm raising perhaps should have been dealt with earlier, but we weren't able to. And I would like first of all to look at the scoping document. I do believe there are differences between Princess Alexandra and Watford, and I would like to first of all point 4 to be added to the key lines of inquiry. It's been found in Princess Alexandra that they're now going to use a greenfield site, and so I think that that's another point. So first of all, under 4, I would like there to be the question of whether the topic group considers that there should be a reference to the Secretary of State, but that can only be determined by the evidence taken on the day, and so it's very much an open question, but something that's been this has generated a lot of interest. And even more has been made by the fact that in the judicial review there was a comment, and the committee was viewed as the watchdog that hasn't barked. I therefore feel that there are elements of the judicial review that criticised the county's health scrutiny committee because we were waiting to see the outcome of it, and so hadn't made any definite opinions one way or the other. So I think this topic group is going to be a test of our ability to scrutinise such a subject, and therefore I think we do need to actually ensure that it does cover the concerns of the residents of the area.
Ron, I can assure you we are not a watchdog that hasn't barked. We will be. I mean, that's a premature. I don't know who suggested that.
Well,
but
that was said.
Sorry. Who said it?
Said in the judicial review, and so
lots of things were said in the judicial review by lots of people, but it is not a fact that the judge has turned around and said we're a watchdog that hasn't barked.
No.
And I do understand that local residents have taken various different stances here on this, but we are here to look at this for the whole of Hertfordshire, and we will do it in the proper manner as we have always done in the past.
So I've got suggestions on the scoping document. And
right. So now you're saying we have recommended, and I have support the key lines of an inquiry. We've recommended 1, 2, and 3 there items, right? You are suggesting extra things to be added in.
Just a fourth, stating that the topic group to determine whether or not a reference should be made to the Secretary of State. And that will entirely depend on the evidence on the day and what the outcome.
Yeah, no, I understand that, Ron, but isn't that an automatic position when planning permission would be given on this, because it's such a large development? I would have thought it would automatically be referred to the Secretary of State anyway.
Well, I think it's this question about which side is chosen, and it basically this is a one-day topic group. We can actually look at the question on that day, and then it's then put to bed. If we don't look at it early, it then means it could come up in the middle of the process. And it cause problems later on, you see.
Yeah, no, I hear that, but I mean, I think that would be the Secretary of State's, that would be up to him. But I'm nervous about introducing things. I'm trying to keep everything the same. I'm trying to keep the key lines of inquiry the same here as they're the same for any other hospital that we have to look at. And I'm not too sure whether we should actually introduce this to the scope, because it could open it up to a whole range of different things that we maybe are not qualified to take a view on. But hold on, Ron, let's just first of all, let's get a view from Natalie. I'm not shooting you down completely. Let's get a view from Natalie and see how she feels about it.
This was certainly something that was discussed at the Princess Alexandra Joint Committee. It would not be something I would expect to see as a key line of inquiry, because it's almost that you're prejudging the outcomes of the deliberations on the day. And I would be extremely nervous about that. I would expect that to be something that the members of that topic group had in consideration if they felt that what they were hearing left them dissatisfied with the evidence provided, and therefore one of their recommendations emerging from that activity would be to recommend to full council that it made a referral to the Secretary of State. It would be an inevitable action of that topic group. It would not need to feature on the key lines of inquiry.
Fine. So it would be a key consideration of the topic group. So I'm happy with that. Right. If we perhaps could move on then. On the second page, there are constraints, and I would ask that the last constraint be taken off, because in a way, this deletes the major concern of those who are challenging the whole of the issue. The scrutiny will not consider greenfield sites, and so that, if you like, if that is then removed, and then under the witnesses that it's allowed that there are representations from interested groups, and obviously they would have to be carefully vetted and everything else. It therefore means that we get a much more comprehensive view of the whole subject, and I've just looked up my notes, and apparently the business of the watchdog not barking was actually said by the judge, apparently. So it's not my comments, and I do believe that we need to make sure that the topic group is operating as widely as possible and to cover all these points, so that we are not criticised about not doing our job.
Okay, I'm not going to get into a discussion and criticise a learned judge, but I think he should know that we have not done our scrutiny of this particular item and it's not finished. So I cannot understand why he says we're a watchdog that isn't barking. A rather peculiar statement by him. Helen has put her hand up very quickly.
So I can only go by what's reported.
No, I'm not. Listen, it doesn't. It's a statement, and if he said it, I don't agree with it. But
Seamus,
Helen, you wanted to come in quickly.
Yeah, just a couple of points of context specifically on that issue. So it's worth remembering that the JR related to the 2019 SOC. It doesn't relate to the current process that we're in at outline business case stage. So it's worth keeping those two things in mind. My understanding of the judge's comment in the JR was to say, if scrutiny had been concerned, they would have barked. They didn't bark, and therefore we assume they weren't concerned. So it wasn't necessarily a criticism of scrutiny. It was a colourful turn of phrase to say, well, scrutiny haven't raised concerns about the 2019 SOC. So that's just for clarity. I think this topic group is focused on the the current outline business case that we're currently working on. Our discussions with Natalie had been, yes, a consideration of the progress to date and the shortlist decision that had been taken, but the primary focus of the topic group really being the forward look around the 3-site strategy and our future engagement plan. Obviously, I'm very well used to being asked questions / challenged on a decision to rule out new sites, and we're happy to cover that with the topic group. But I think it is worth being clear what the key purpose of the topic group is.
Okay. Thank you for that. Listen, we've got a number of members that want to speak, as well as, I think, Jane, you put your hand up. I don't know if it's still there. What I'm going to do is allow you, Jane, to come in now, and then I'm going to not take any more interjections from the health side of things. I just want the members to come in. So, Jane, do you want to come in and just say your bit now? Yeah, I can't hear.
Short practical point, Chair. Natalie, neither David nor myself received any diary hold the date notification, and we are both now committed to a full day meeting on the 1st of February. So it's just to flag with you that we will have to think about attendance, because we are neither of us going to be able to attend now.
That's a real nuisance. Okay, that's Natalie. We'll have to sort out, the administration will sort all this out afterwards. Natalie, did you want to come in before I start bringing councillors in here on what Ron has said up to this moment in time, or Ron, do you want to continue?
No, I don't, Seamus, thank you.
Can I just say, Seamus, thanks to you. No, I'm happy to leave it there, and you've got my points in my email to you yesterday, and so that clarifies the situation. And I'll be happy if the scoping document can be changed accordingly. Okay, we'll deal with that bit afterwards. So I've got Margaret, Gordon, and Chris White. Margaret, you wanted to come in next.
Yep. Thank you, Chair. Two important things really. One was quite quick, which is just to do with the seminar that's on drug and alcohol. I mentioned in our briefing we had a very good public health cabinet on this, and that I would really like you to use the report that was presented at the public health cabinet to make sure the seminar includes housing and the joined up nature of care of drug and alcohol after treatment, not just the treatment. I think you got that before, Fiona, didn't you? Did. I meant to give you the surname of Louise who wrote the report, but I will try and you can actually look that up in the papers from Public Health Cabinet, that she was a recorded speaker. The second thing, and that I think that is really important in thinking about the joined up care of people. The second thing is this, the West Herts Hospital topic group, the scoping day. I'm not actually happy with the introduction, especially because at this moment we've had some key news today, key notifications on the role that Watford Hospital will play in the future. And it's not just to West Hertfordshire population, it's actually to the whole of Hertfordshire, particularly on cancer and its role in revascularization and coronary heart disease. So I would like that the beginning to actually say, let me just go back to what it actually says, where it says to assess the extent the proposals are in the interest of the health service of West Hertfordshire. It's actually the health service of the whole of Hertfordshire, the proposed options that will improve the health of both West Herts and East Herts citizens.
I think, Margaret, there will be a big piece of work done around Mount Vernon, right? You've heard it's at a very early stage. What we are dealing with here is the HIP in relation to the Watford campus site. I don't think we can at this stage introduce anything that's happening in Mount Vernon into this particular scrutiny scope, because it is University College in London is running the system for the Mount Vernon. They're looking after Mount Vernon. We need to scrutinise them rather than bringing them in here. I think it would be an absolutely mismatch of a situation if we tried to include something which, number one, hasn't been funded, number two, is only at a very, very early stage into this particular topic group. Because if we did that, we would then have to postpone the whole thing until we had an awful lot more information about Mount Vernon and when Mount Vernon is actually going to happen, if it does happen. Remember that it's only just beginning. It hasn't even got funding. So I mean, it wouldn't be right.
Forgive me, Chair. This is not a detailed, requiring the detail of how Mount Vernon will change. It is to do with strategic planning for Watford and realising we've already had announced the vascular hub and spoke model, which is very important. I'm very pleased to see it, and it is actually to do with the joined up nature of health services across Hertfordshire relating to East and North as well as West Herts.
I've already given you my view. It's categorically not going to be involved in this particular topic group. A topic group like this it's very important we move ahead now with this particular topic group. We cannot be holding it back because of trying to get involved.
I'm not trying to hold it back.
No, would it have to be held up? Because
I'm trying to say strategic planning for 2025. So you've mentioned 2025.
I'm sorry, I've made a decision that we are not going to get Mount Vernon services and cancer services discussed into this particular topic group. We will deal with that by itself at the appropriate time. We can't get involved in it because what's going to happen is it'll go all over the place and it will be too big and it'll all be ifs and buts. And then you'll be saying to me, it's not focused. So what I have to do is actually make sure that we get the right result in this topic group and reflects the members and so that this committee can make a decision on what they say. So I'd like to see what we have here on the papers. I'm sorry you don't agree, but that's the way it is.
But it includes coronary heart disease as well.
If we put it that way.
It's not just cancer, and the coronary heart disease has been announced, and it is to do with the ICS. So I'm just trying to put in context the joined up thinking.
I'm not going to allow it to get any bigger than the scope we have here at the moment. It'll get too complicated, a beneficial result. Right, and I think as we heard from Helen Brown there, right, that the judge expects us to be looking at this, and if we find anything incorrect right? He has to raise it. I don't want to be getting involved in things that aren't in reality at the moment. It's at a very, very early stage, the cancer situation in Mount Vernon, in potentially moving to another site. I think it's a brilliant thing that they want to come into Hertfordshire. We will look at that as a particular piece of work at that time. Now, I'm going to draw the conversation closed on that. Is there any other points you want to raise, Margaret, on this?
Only that I do think inequalities and what has happened in COVID in widening inequalities is becoming quite an important topic group to try to find a date for sometime in 2021.
Yeah, I agree with you. I totally agree. And, you know, it's another thing I'd say here to everyone. We have very limited resources in Scrutiny. There's so much important work we've got to do, and we have to keep focused on the, you know, what is in front of us. And you have said, Margaret, and I do agree with you, that particular piece of work is very important. And Natalie, I'm hoping you can find a day to do it. Now, listen, I've got Gordon Nicholson and then Chris White, so I'm going to take Gordon next.
Yeah, thank you, James. Just further clarification, I've got a little bit confused here with all these conversations going backwards and forwards. I was referring back to Ron's comments. Was he in fact referring to the PAH site at all in any of his remarks there, or is it strictly moved on since then?
Okay, this is the difficulty with it. What I'm trying to do is to get everything the same. So in other words, that challenges can be reduced. You know, that the possibility of a challenge can be moved away from us. And that is why I'm reluctant to put anything extra into our key lines of inquiry. And I'm also reluctant to get to moving on the constraint question about the scrutiny won't consider greenfield sites. I don't believe that needs to be changed. I think it should be left alone. That would be my recommendation when we come to vote. Yeah. But at the end of the day, we're a democracy, and everyone will make their own mind up.
Fine. Look, I'm trying to back you up on this, Seamus. If we're talking about the PAHA, could I respectfully remind everybody that this comes under the Essex Health Trust and it comes under a different council? We have been very, very lucky over the past few years that we have been included in some of the thinking that's going on with the Princess Alexandra Hospital and been able to get on the committee and become involved in these. But ultimately, it's down, firstly, it comes down to the Essex council, and if they put a planning application in, I would think respectfully it would still follow. If it's a greenfield site, the normal thing is it was referred, if it's not in the local plan, will be referred to the Secretary of State. So I don't know what all this backwards and forward stuff is. That, as I understand it, is the correct procedure, and unfortunately it's out of our hands in that respect. It's down to Essex and not Hertfordshire. I hope I'm correct in this information.
Yes, you are.
Thank you very much.
I take it, and thank you for that support. Chris, did you want to come in now?
Yeah, on a number of points here, and we are in danger, and I always fear this in doing a pre-scrutiny exercise, which means that people like myself have got to declare interest because I have taken a clear view. We mustn't do this. It really is quite wrong. And what we have in front of us, in case of West Herts Hospital Trust, is a proposal. That is what we scrutinise. We do not have a court of inquiry into the management of West Herts Hospital Trust, which is basically what these additional requests can amount to. And I would add that in relation to greenfield sites, there were two astonishingly inappropriate sites mentioned and dismissed rightly by the Trust, inappropriate in planning terms, particularly one which has caused the District Council, of which I am leader, massive grief in terms of the local plan and interface with inspectors and a different Secretary of State. So if we did start looking at greenfield sites, which would be inappropriate because it's not in the proposals, then we'd have to have representations from St Albans District Council, probably using Cancel, and I'm not sure that any of us would forgive the fact shelling out for barristers to deal with these complex matters, merely to restate what should have been obvious to those who suggested it in the first place. In terms of what's just been suggested in terms of PAH, it's entirely right. That was dealt with under a joint scrutiny process led by Essex. The situation for Mount Vernon, which is not the proposals we have in front of us, and therefore nothing to do with this particular scrutiny, will in any case be a joint scrutiny, and it would be close to unlawful for us to start scrutinising in any sense potential proposals from Mount Vernon. These have to be dealt with by a joint body, possibly led by us with Hillingdon, possibly led by Hillingdon with us, and maybe others. And therefore, we've got to keep this one clean and do this properly and deal with proposals which are in front of us, not proposals which have not yet been worked up, nor indeed proposals which have been rightly rejected as entirely unsuitable.
Okay, thank you. So does anybody else want to speak on this? What I'm proposing is that we could agree everything outside the, apart from the Watford scoping document, and then we'll take a view on that one by itself, if we could put it that way. That would be a lot better way of actually getting, you know, that was of showing the committee's view. So basically, can I ask everyone to agree the majority of the health scrutiny programme, but apart from the NHS Watford HIP one, Appendix A 2A, which we'll vote on separately. And as usual, Michelle, if you can tell me when we get to the majority. Are we there yet? Must be getting there.
Majority agreed, Seamus.
Yeah, great. Thank you for that. And I think that actually makes it slightly easier rather than a complicated vote over this Watford one. Right now, so we've got a situation where Ron wants to add, wants to take something out and add something in. Now, I personally am against that.
Can I help, Seamus, in the view of something that Natalie said?
Yeah.
I may have to be helpful. Can I withdraw my suggestion for a fourth line of inquiry? Natalie said that that could actually be part of the topic group's deliberations through the day. And so on that understanding, I'm happy to take my suggestion about the fourth line of inquiry out if I could get my other two suggestions.
Oh, well, is it? I don't know. Yeah, we're going to vote on it, right? So I think the way we could, how am I going to do that? I think the way to deal with this is, can I can I ask if members would vote on what they have in front of them as it's written down now, and what is our recommendations, and if that falls, we'll then go back to Ron. Natalie will go back and we can have a talk about how we can add things in. But I think the best way of doing it is that way. It's the fairest way of actually voting on what's in front of you, which is on Appendix 2A in relation to this. So this is as it is at the moment. So colleagues, if you agree to this, will be passed. If you don't agree to it, we will have to revisit it to reword it. Okay, colleagues, can I ask you if you agree?
Mr. Chairman, can I come in? I can't seem to get into this. Could I verbally say I agree with your recommendations?
Okay, we'll deal with that at the end. Who is that?
Councillor Nicholson.
Gordon. Okay, we'll add you in at the end.
It's just I haven't got access to get in. I've done it several times. Nothing seems to be coming through.
Now, I do understand that sometimes with these Teams things, it can be very, very difficult. We experienced that at full council the other day when there was an awful lot of problems over voting.
Thank you very much. Yeah, I've done it on every item so far and nothing's appeared. So obviously I haven't the means to communicate that way. My apologies.
Don't worry. So, Michelle, if you could have a look at them and tell me what the situation is. Do we have a majority in favour of what we've got on the papers? And if you could, I think it's fair to say as well, if those who are against this particular proposal, if we can have it minuted, if they so wish, want it minuted, like Ron might want his name minuted, that he opposed this particular scope.
I'm just checking the results, Chairman. I'll let you know.
Yeah. Yeah, fine. I don't know, whilst Michelle is looking at that, if there's anybody else that wants to be mentioned in the minutes that they oppose this particular item, where we can do it.
Seamus, Richard Thake has a hand raised.
Richard, did you want to come in now?
I do, Seamus, but purely and simply to assist Gordon. We found that the best mechanism for dealing with this voting problem and for the failure of chat box to work is to come out of chat and then go back into chat, and that seems to clear the cache, and then you can then use it. So for any member that's had problems with voting and typing messages into the new message pane at the bottom of the chat box, just come out of chat, tap the chat icon at the top, and then back in again, and that should clear it. And we found that worked very well at full council.
Thank you, Richard, but I don't seem to have an emblem for chat.
Oh, right. Maybe you're not working on the
I've
same
tried
system.
everything on the book.
Chairman.
Thank you for your help anyway, Richard.
Chairman, if I could come in, it's 10 for, 1 against and 2 abstentions.
10 for, 1 against and 1 abstention. So the topic group scoping document is now passed and agreed, so thank you for that. As we've agreed everything else in the work programme, I think that's that. So then we move on now to Annie. Oh, by the way, Ron, we will note your comments that you voted against it in the minutes. So that will because you've been quite strong about this over the years, you know. So I'll note that.
Thanks, Seamus, and thank you everybody for consideration.
No, we you know, it's important that these things are done in a proper and sensible manner, so we get the right, so the result is clear. Now agenda item 10 is other part 1 business, and there isn't any. 11 is the standard item for county council. In fact, we basically do a report. The whole thing goes to county council because we do a report, and you can discuss it again there. You could have the opportunity of going through the whole thing again. Now those county councillors. So we're now at the end of the meeting, and it's now my duty, I suppose, before I close the meeting, to wish everybody who takes part in the Health Scrutiny Committee over the last year, everyone who's worked hard, the officers, you as members, right, a really merry, happy Christmas. And also, the most important thing is stay safe, and make sure that you watch out in relation to the regulations. And I suppose, as Boris Johnson says, less is more in this occasion in relation to the number of people you're meeting at Christmas time. But have a great holiday, a good rest, and we'll see you all in the new year. Thank you, everyone.
Thank you, Seamus. Same to you.
Thank you, Seamus.
Thank you, Chair. Have a good Christmas.
Thank you.